Okay, good day, ladies and gentlemen, and I want to thank you for being here in the first session of the World Conference of the Hellenic Medical Diaspora. It was a pleasure helping organize this Congress, and we feature over 100 or probably 200 Greek medical scientists in this two-day Congress, and I'm very proud of what we will present. The first session is about innovation in medicine, and obviously to first talk about innovation, we have to think, what is innovation? Is innovation only a tool, an invention? Yes and no. Invention is an innovation, but innovation is just not an invention. Innovation is a way of solving problems, like the way Fosbury thought that we should jump backwards during high jump, or Semmelweis that we should wash our hands. And innovation has many phases, from idea to adoption. So it really needs to be managed and nurtured to flourish. So this is an appeal to the institutions or the representatives that are here with us and hearing us, that you have to nurture and protect innovation to be able to, the people to do the innovation, that to be able to do this. We will be having speakers today that will present various kinds of innovations, from Professor Vasilios Papalois, that will be talking about technique innovation, machine perfusion in transplantation, Marios Papadakis, that we will be talking about technology tools that can be used to prevent and detect surgical never events, a very important part of surgery. Mr. Kostadin Strantakis, that will be talking about private investment and a new biotechnology park that is planned in Greece that will help nurture this kind of innovation. Mr. Apostolis Stasiopoulos will talk about the quality of surgical care and how can we measure it. A student that will talk about, William Mezitis, that will talk about the innovation in terms of the Hellenic youth. And of course, Mr. Dimitris Karousis, that will be talking from stem-cell therapies in neurology. I want to thank you all for being here, and I would say let's begin. So I will first welcome the first speaker, Professor Vasilios Papalois, who is a professor of surgery and transplantation surgery in Imperial in London, and also the president of the UEMS. I think Professor Papalois will be talking online.
Can you hear me?
Yes, yes. Good morning from Thessaloniki.
Good morning from Anafpaktos, actually, where I'm here for my very short summer vacation, and that's why I cannot be with you in Thessaloniki. I was in Thessaloniki a couple of weeks ago, where we all celebrated the 40 years of the transplant program in Thessaloniki, and it was a fantastic occasion. I would like to thank the organizers of the Hellenic Medical Forum, the Aristotle Medical Forum, and especially Dr. Theodorou for his most kind invitation, and also to be in the company this morning of such an esteemed group of colleagues, including my good old classmate from our high school years and university years, Professor Stratakis. I will bring my slides in now, and I hope that you are able to see them. Can you see my slides?
Yes, yes, we can.
Brilliant. So in this session about innovation, I would like to focus on something from my area of work, my area of expertise, which is transplantation, and more specifically about pancreatic transplantation, and to show you by using this model more specifically, the use of machine perfusion in the hypothermic and normothermic setting, which has really opened a new era in the field of organ transplantation when it comes to our ability to preserve organs, assess their condition, and also improve their condition prior to implantation. To put this a little bit into a background, we will see here the activity report for 2020-2021 by NHS Blood and Transplant that regulates transplantation in the United Kingdom, where I live and work, that sets the scene of what we are trying to achieve by introducing machine perfusion. And if you see here the overall data about organ donation and transplantation in the UK, over the last decade, there was a clear increase for almost 50% plus of the number of donors, with of course, a subsequent increase in the number of transplants. And this closed more and more the gap between the people waiting on the waiting list and the organs that we are prepared to offer to them. But there is a reason for this. And the reason for this is not so much the increase in living donation, which has been static more or less over the last decade plus, but an increase, a significant increase in donation after brainstem death, especially in the context of extended criteria donors with mild, moderate, and many times significant comorbidity, and also the introduction over the last decade plus of donation after circulatory death, DCD donors, which has been another real big revolution. But all these donors are extremely challenging donors because of the very prolonged warm ischemia time prior to retrieval. To this, we need to add that we are dealing also with a more and more challenging population. As you can see here, the population is getting older and the population is getting more obese. And to this, we have to add all sorts of other comorbidities, like, for example, atheromatous disease and diabetes, and so on and so forth. So although we have a massive increase in the number of donors, we are dealing with a very challenging cohort with extended criteria donors and DCD donors that we need to deal with, because this is the population we're working on. More specifically, for the organ I'm going to use as a model for pancreas, is a very challenging organ. I remember when we were trainees, my professor used to say, don't even look at it, let alone touch it, operate on it, bench it, and transplant it, because it can get really angry on you and create all sorts of problems. And I will show you here just the tip of the iceberg of all sorts of problems we can have with a pancreatic graft, like, for example, the difficulty to flush out the small vessels in the parenchyma that can lead to thrombosis, the phenomenon of steatosis, which is massive, intraparenchymal and periparenchymal steatosis, and also the phenomenon of chronic pancreatitis, most common phenomenon, most unfortunately in the Western world, due to the massive consumption of alcohol. So very difficult organ per se, but extra problems with the pancreatic grafts. Another problem here is a technical problem where all the contributaries to the portal vein have been ripped off, and you can see leak of the perfusate around the portal vein and not through the portal vein. Furthermore, because of this, as you can see here, when we see the data about the organs that we actually use from the potential initial cohort in the United Kingdom over the last year, when it comes to donation after brainstem death, only 11% of the initially considered donors are used finally for pancreatic transplantation. And the percentage is even smaller, 6%, when it comes to donation after DCD death. And this slide here tells the whole story, where approximately 1 out of 2 of retrieved organs, finally they go to the bin, basically, and they are not being used for a variety of reasons. Most of them, as I said, because of extended criteria donors or anatomical abnormalities. And usually this is being done based on a very subjective evaluation on behalf of the surgeon, without anything objective and concrete to decide one way or the other. Therefore, we have something here which is massively important. We have this huge increase in the number of donors, but we have the challenges, as we said, and we have the problem that we are throwing 1 out of 2 organs in the bin. So we need a new way to be able to assess the condition of these organs in a concrete scientific way, and not in a subjective way. This is too fat, too small, too big, too this, too that. And also we need ways to be able to recondition them, to improve the condition of the parenchyma prior to implantation, so that A, we will increase the pool of organs that we can use, and B, we can increase the transplant outcomes in the short and long term. Here it comes, though, therefore, the introduction of machine perfusion, of the extracorporeal machine perfusion. It is not a particularly new idea, actually. It was something that Alexis Carrel and Charles Lindbergh, classic example of collaboration between completely different disciplines, medicine, surgery, and aviation, have created the first machines of this nature almost 70 years ago. And it was Volker Belzer, one of the pioneers of organ preservation, that created the first one that looks pretty similar to the ones we are using today. At the time, as you can see, it was the size of the small car, and you needed a van to be able to transport it. Of course, over the years, the technology improved, and they are today totally manageable. So it is not a new idea. It's an old idea revisited under a completely different prism. The advantage of hypothermic machine perfusion, and the same stands for normothermic perfusion in the extracorporeal setting, is that it is offering a very controlled environment in low temperatures, where you can basically assess not only the hemodynamics of the graft and see how they are evolving over time, but also you can intervene. You can intervene in all sorts of ways to be able to improve the condition of the organs. And that's why in the United Kingdom, and the same stands for many other regulatory authorities around the world, the NICE Institute, the National Institute for Health and Clinical Excellence, introduces and recommends machine perfusion as an element of very good practice in modern transplantation programs. Of course, now we used to have a plethora of them, and it was a very impressive thing to see that in the last Congress of the European Society of Organ Transplantation in Milan, more than 70% of the exhibition area was occupied by new machines in this exact context. And this phenomenon increases by day, and it's really, really important. And all of them are available, they are easy to use, and they offer an enormous amount of capabilities. The model we wanted to test was a translational model before we go to clinical practice, and we're about to go to clinical practice. And this was, the lesson I learned from my teacher, David Sutherland, the father of pancreatic transplantation. And we want to use a model, as he always said. You want to, not to change the lives of the rats and the rabbits and the mice. You want to change the lives of humans and improve the lives of humans. So whatever you do has to have this translational character and be applicable to humans. And the model we used, first of all, used machine perfusion to assess the hemodynamics and improve them, therefore assess the condition of the macrovasculature, and also to see the condition of the parenchyma by using more specifically microdialysis techniques that gives us a much better idea of what is happening in the parenchyma, in the microvasculature. And in this model, we used the human pancreases that they were disregarded in the United Kingdom for clinical transplantation for a variety of reasons. So they were really, really challenging and difficult organs. You can even call them bad organs. So we used, of course, the perfusion by the typical Y graft in pancreatic transplantation, where the Y graft of the common internal and external iliac of the donor is being used to be anastomosed to the splenic artery and the SMA of the graft. The cold ischemia time was really wild, 24 to 56 hours. And we were using a model of 5 hours of hypothermic perfusion that was then replaced by 2 hours of normothermic perfusion using, Krebs, 2% Krebs, that was mimicking basically normal circulation in the reperfusion setting. The anatomical reconstruction of the splenic and the SMA with the Y graft, as I told you. And of course, the perfusion can be done either by the Y graft directly or by 2 different perfusion cannulae by the arterial system and the portal vein system. And what we saw during the perfusion in the hypothermic setting is that the pancreas, especially when you work on it in low pressures, because it's a low pressure organ, maintains excellent hemodynamics and that are improving gradually during the time of machine perfusion, especially in the context of reduced resistance and increased flow. And also because you have enriched the perfusate with mannitol, the pancreas didn't become like a balloon. The big enemy of machine perfusion is a lot of gain weight of the organ and edema. It was only 9.3% compared to the pre-perfusion status, which was really remarkable and most helpful, especially in the post-transplant setting. And when these organs were then from the hypothermic setting transferred into the normothermic setting with the 2% Krebs, the pancreas more or less came back to life. Both the endocrine and exocrine function of it came completely back to normal, and it was responsive to what we were doing to it, which was really impressive to see. So we had a model, a very translational model that was working very well using human pancreases. And then we wanted to tackle one step further in using this innovative technology, to prevent the phenomenon of thrombosis of the pancreatic graft, which anyone who is involved in the field of pancreatic transplantation knows very well that it is the Achilles heel of pancreatic transplantation. And what we wanted to do is to provide anticoagulation where it's actually needed in the organ, not systematic anticoagulation that can end up with all sorts of complications, but really, anticoagulation within the pancreatic graft. And the model that we used here, in collaboration with King's College, it was the production of thrombalexin, which are basically some novel cytotopic fusion proteins that they have an anticoagulant uridine-based head, an endothelial binding tail. So the tail gets stuck into the endothelium of the small vessels, and the anticoagulant element is hanging in the breeze in the lumen of the vessel, providing anticoagulation where you actually need it. We used the RM3 machine to be able to introduce these proteins and do our experiments. This has been now evolved into the RM4. And the beauty of this machine is the fact that you can perfuse two organs. It has a pulsatile perfusion, which I think is absolutely crucial because it mimics natural circulation. And finally, it gives you all sorts of avenues to be able to intervene in the graft during the time of perfusion. And the whole setting of the experiment was pretty straightforward. Initially, priming with University of Wisconsin solution into the hypothermic setting, then introduction into the perfusate of the proteins, and finally, reperfusion of the graft with partially heparinized blood to mimic the normal circulation. And you can see here, of course, that we confirmed, first and foremost, that the proteins were stuck into the parenchymal of the pancreas before we proceed with any further experimentation. And what was impressive to see is that from the moment we went from the hypothermic setting to the perfusion with partially heparinized blood, those pancreases that they were treated with the proteins maintained more or less normal hemodynamics, while the control ones, immediately you needed much more pressure to flush the blood through it. The resistive index went through the roof and the flow went through the floor. And this was clearly a difference between the two that we have seen also in the kidney setting as well. Also, we use the cytoscan that gives us the fantastic ability to scan the flow of the erythrocytes into the small vessels of the pancreas for a much better evaluation of the effect of what we are doing in the micro circulation. And it was very, very clear that the pancreases that they were treated with the antithrombotic proteins had larger vessels and a much better flow of the erythrocytes into the macrovasculature. Furthermore, with a macrodialysis technique that gives you the fantastic ability by putting a small, tiny microscopic probe into the parenchyma of the pancreas and see in overtime and in real time the condition of the parenchyma, it was evident that the pancreases treated with the proteins in the normothermic reperfusion setting were producing much less lactic acid compared to the ones that they were not treated with the proteins. Another clear example of the difference and the effectiveness of those proteins. From now on, we have, as I said, an evolution in this, fantastic new era in the field of transplantation, and we try to produce machines that are organ specific. We are trying to produce new preservation solutions that gives us maximize our chances not only to preserve but also to recondition. And we are testing all sorts of new modalities, from stem cells to xenon to short-acting mRNA. The list is absolutely endless, to see how we can improve the condition of these organs and therefore maximize the donor pool and the post-transplant outcomes. I would like to express my most grateful thanks to my PhD students for their absolutely amazing work, some of it which became first page in the Journal of Surgical Research. Of course, our funding bodies and you, dear colleagues and friends, for your kind attention this morning. Thank you.
Thank you very much, Professor Papalois, for this very innovative technique and project that you presented us. We will move to the next speaker directly as we are pressed for time. I would like to welcome to the podium Dr. Marios Papadakis. He's a general and plastic surgeon, and he is an associate professor in the University of Wittenherdecke in Germany. And he will be having a talk about, let's say, technology tools that prevent and detect surgical never events.
Good morning. Many thanks for the invitation, Alex. My topic is about surgical never events and the technology tools that we have to prevent them. I do not have any conflicts of interest. I haven't received any funding. And I would like to start with a general introduction about errors. It's human nature to make mistakes. All people in all works make errors, but some errors are simply unacceptable. The operating room is a special environment. There is an interaction of technology-based components and human-based components, so that errors are very frequent. How do we define never events? They are unacceptable deviations from the standard of care. In other words, they are mistakes for which there is simply no excuse. And near misses are events that could have led to never events, but did not. For example, the wrong side was marked, but the correct side was operated at the end. In surgery, the term refers to wrong side surgery. So we operate the wrong side, the wrong part, the wrong patient, or we perform the wrong procedure. And also retain surgical items, unintentionally retain surgical items, a term which is much better than the old one of retained foreign bodies, because the latter can also be non-surgically replaced. We should not confuse never events with malpractice or complications. Never events do not require any special training and can very easily be prevented. In numbers, I will skip these slides to remain on time. It's important. Once every 15 or 30,000 operations occur, so I never event. The leading specialty is orthopedics. And in our field, hand surgery and plastic surgery, 1/5 of hand surgeons have reported at least once the wrong finger, to have operated the wrong finger, and 2% twice. Retained surgical items are much more common. And in most cases, the items are sponges or needles. In many cases, interestingly, the retained items are found in airports during pre-flight security processes. And they, of course, they gain attention in the media. We see here a case of a man in Nigeria who found he was operated 50 years ago and a scissors, or it is a forceps, not a scissors, was found in his abdomen. The theory, there are always team errors. Every person involved in the operation process is equally responsible, and it's not considered though the surgeon's error anymore. There are two models to explain the theory and why do they occur. The first one is the switches model. So the holes represent failures, and the layers represent our defense against failures. So if we multiply and if we amplify the layers, if we add defenses, it's very difficult for holes to align in the same line, so that errors do not occur. The other theory is from Heinrich, described in 1930. He made a pyramid with major incidents, minor incidents, and near misses. And he said that these all errors share the same common causes. And we have to eliminate the minor incidents and the near misses to prevent major incidents. They always if we operate the wrong side or if we forget something in a cavity, is always a communication breakdown, the cause. The consequences, I have to skip this. We can imagine that it's devastating, for the healthcare system, for the healthcare provided. These are all cases that gain massive attention from the media. For example, here. And of course, for the patient, resulting in mortality, 2%, 10%. So how we can manage never events? Who implemented the checklist? The so-called surgical safety checklist in 2008, which has 3 components: a sign-in process, a timeout process, and a sign-out process. We have for all these processes the technology tools that we can use. The sign-in is the first procedure, is the first process, is the verification process. We have to verify that the correct patient is about to be operated. Of course, we can mark our site with a cross, an X, a smiley, or with our initials, and perform also operating briefings. But the main tool here, the main technology tools, are barcode stickers and wristbands. The barcode stickers consist of a computer system that generates labels, and we can scan them when run with a handheld scanner. But this was FDA approved 2005, but it has been replaced by the wristbands. The wristbands are a very good tool. They cost 200,000, until $1 million for a tertiary hospital. They do not have contraindications or complications. They reduce the incidence of medical errors around 60%. And when combined with barcode medication scanning, they can also save time. But they also have problems. Approximately 10%, they have the wrong name written or a wrong surname written. For example, I work in Germany, and if we write Meyer with I or Y, there's 5 different things. And we had the case. We had a near miss. We were about to operate the wrong Frau Meyer. And the compliance is very low in pediatric departments. The second process is the timeout. The timeout procedure is a short pause of the surgical team just before incision to confirm that the correct side is about to operate it on the correct patient. Here is a review in the International Journal of Surgery, and we see here the components of the timeout. All these have to be verified. It's called out from the circulating nurse. Ideally, she holds in the one hand the wristband, and in the other hand the informed consent of the patient, and she carries out the timeout without being interrupted. And if all agree, the operation can start. It's very easily performed, does not require any qualifications, can be repeated as many times as necessary, it costs nothing, is very fast, and does not add to stress. But although everyone agrees it's useful, nobody performs it still. And all studies report an unacceptably low compliance rate. So there are some tools here to increase compliance with this procedure. There are sterilized metal plates during the whole timeout to remind of its necessity. Simulation-based learning programs and delivering of the checklist via audio. But all these instruments their efficiency remains to be proven. There are no studies about this. There are only recommendations. And the third one, the most important, is sign out. So we have to be sure before we close that nothing is left behind. We have three tools. Manual surgical counting is the first tool always. It's very important. when we operate in open cavities, abdomen, thorax, and lasts a minute. And if there is a cauda cordis, it allows end of the operation. It has a relatively low sensitivity, and in most events where something is left behind, the count is correct. We see here on the right-hand side a rack with gauzes, with sponges counted. And if a discrepancy occurs, it has to be resolved before we're allowed to close. So that adds a mean of 13 minutes. And in the US, everything is measured. Operating time costs $20 to $30, and the patient is charged on the patient is charged $62. So that makes an average cost of $200 to $300 or $1,000 per discrepancy. And the next step is to use a portable X-ray that also costs about $300-400. So that's how it's performed. That's a very good tool. That's very efficient. We have to perform it 300 times to find one a retained surgical item. Most sponges, though, are radiopaque, but the sensitivity is very low, 67%. And the problem is the needle size. Every needle smaller than 1 centimeter cannot be seen in the portable X-ray. And of course, multiple foreign items are also a cause for the low sensitivity. We want to be sure that no sponge is left behind, so we have three tools here. The first one is the data matrix code system. That's a counting tool. Soft goods, sponges are scanned before being added to the operation field and immediately after they are removed, but the system can detect only sponges in direct visual proximity to the scanning device, like the barcode systems used in a supermarket. And the cost averages on $12 per case. That's a counting tool. That's how it looks like. It's cost effective. It has been proven it's cost effective, but also has some problems that are very, very rare. The second system, radio frequency tags, that are incorporated in soft goods and can be detected within 60 centimeters of the detection wand. And the console generates noise when a sponge is detected. And this is a tool that can detect but cannot count. That's here. And the combination of the two, that is a very good, cost-effective, 100% sensitivity, costed nothing, and it can resolve very fast miscounts. So you can save up to 18 minutes. And the combination of the two is a tool that can both count and detect. And that are the RFID systems. They are based on microchips data transmission after interrogation with specific electronic queries. The chip is embedded in soft goods who are counted and identified through a signal. And this can also resolve discrepancy in less than 1 minute. And a radiograph to compare requires 20 minutes. So to conclude, the best action against never events is prevention. Never events are very easily preventable. Technological tools are available, but for some of them, efficiency has to be proven. And we have to use these tools to ensure that the procedure is performed safely. So better safe than sorry. I'm finished.
Okay. Thank you, Marios, for your excellent presentation. As I said, we will be going direct to the next presentation as we are pressed for time. And I would like to welcome Professor Konstantinos Stratakis from Crete. He is the research director and head of human genetics and precision medicine in the Institute of Molecular Biology and Biotechnology Unfortunately, you couldn't be with us, but you're in here today. You're in Crete, so I welcome you to the presentation.
Thank
Can
you
you
very
hear
much.
us?
Can you see me? Yep.
Yes, yes, we can see you and hear you.
And I'll start sharing my screen. Sorry for that. Do you see my screen?
No, not yet.
Not yet.
You have to go to presentation mode.
Do you see my screen now?
Yeah. Yes. Yes. Now we see it.
Great. Thank you so much. I want to thank Dr. Theodorou for the invitation. I want to thank the organizers, and I want to congratulate you for what you're doing. I think this is extraordinarily important. Sorry for this. So I am presenting to you today on a tremendously important new effort that is happening with primarily private money, but with the endorsement of the state in Athens, Greece. And it is also, of course, since I'm also a scientist at Forth here in Crete, it is also something that's supported very much by Forth. This is the Athens Life Tech Park that is funded by the biggest, most important, perhaps, Greek pharmaceutical company, the Alpine company that I'm very fortunate to be the chief scientific officer of. This is the building, how we envision it. And let me just tell you a few words about Alpine. Alpine is a large group of companies. It employs more than 1,200 employees. We have a turnover of almost 300 million euros. It is entirely private. It's not public yet. And we are a group of at least 3 companies right now. So there's the Alpine, the original company that was founded in 1965. That's in the center of the slide. And then 2 smaller companies that started in 1995, ＭΩΡΙΣ, and 2008, Win Medica. These 2 companies that are smaller are companies that focus on specific areas of the drug market in Greece. How it all began. So our founder was a pharmacist, is a pharmacist, Dimitris Pentafragas. And he established the company back in 1965, truly a visionary man, tremendously innovative, and understood very early that you can't do pharmaceutical business. I would argue that you can't do any modern business without R&D. And so in 1996, Dr. Pentafragas established the Research and Educational Center of Alpine, which is still functioning today, and that for many years was led by the brother of one of our previous speakers. So Vasilis Papalois has a brother, Dr. Papalois, who was the head of the established and was the head of the Research and Educational Center until very recently. Now the center is headed by Kyriaki Bagirtzi, an outstanding biologist whom we recruited from the United States, was recruited from the United States actually before I came to Alpine. The center, the new park, is really establishing a new era for life sciences in Greece. You can see here the individual components. The way we see it is generating essentially an ecosystem, a new ecosystem, the way we see it. I mean, imagine having a CRO for clinical studies and preclinical studies, a research center, a biotech startup incubator, as well as an education and conference center, all of that supported by core facilities, such as, for example, the biobank and the vivarium that will have animals for experiments. In addition to that, as you can see, there is an athletic center. So this is, of course, all laid out in a land that is what you see here in the middle of the Mesoia fields outside Athens and very near the airport. I'll show you the map. But the point is, imagine something like this being in the entire area of Mesoia or the entire area somewhere around Salonika. And this is what an ecosystem of a modern complex between industry, academia, and research would look like. And so we are generating in a small scale right now what we think will be the future of research. What we know is the future from similar establishment around the world. Here's where the Athens Life Tech Park is. It's in the center of Mesoia between Pikermi and Spada, and we are just 9 kilometers from the airport. The biotech incubator is the first of its kind in Greece. In other words, an incubator for startups that will be dedicated to new components around life sciences, which will also offer the ability to rent out wet lab. That's what makes it unique. This concept of lab for hire doesn't exist right now in Greece. It started only about 10 years ago in United States, in the Cambridge area from MIT and Harvard. And it now expanded to Europe. Cambridge in the UK has it. And of course, there's several places, lab for hire in Switzerland, where pharmaceutical companies quickly realized that it was much cheaper for them to rent lab space and staff for a certain amount of time to do what they wanted to do instead of actually building the infrastructure to support their own R&D. The biotech incubator will be supported by highly specialized core facilities that will also be the same core facilities that we will use in the Research Institute. Likewise, the preclinical CRO will use the existing expertise that we have in the current LPENS Research and Training Center that is headed by our scientific director, Dr. Kyriaki Pagirtsi. This CRO will provide in vitro and in vivo non-GLP preclinical study services, again, a first in Greece. And the services we will offer will be everything from toxicology to pharmacokinetics and pharmacodynamics, where we're able to house multiple in vivo models of disease, and of course, we'll have extensive cell culture facilities. The Research Institute, it is going to be the first private, totally private, not-for-profit, of course, research institute in Greece. As I said at the beginning, I'm a scientist at Forth, that also is the chief scientific officer of LPEN and the director of this research institute that we're building in Athens. And so, as you can see from this setup, this is a research institute that is, in fact, focusing on research. What type of research? It will be translational, but it will use basic research that facilities at Forth and elsewhere have, as well as use some of infrastructure that we will build in Athens. At this point, the type of infrastructure that we'll have available in Athens depends on the types of affiliations we have. As part of our way to the future, we have applied for a Horizon 2021 program, and we hope that we will be funded to house in Athens part of the new Fotis Kafatos Center of Excellence in Molecular Biomedicine, so aptly named after who we all consider the father of establishing research institutes from outside in Greece, Professor Fotis Kafatos, that I also had the fortune to meet when I was a kid from my family. He was a family friend, as well as later on when I became a scientist. The focus of the new research institute at the LPEN Park will be on precision medicine. That's my expertise, but also that is what we feel will be needed in Greece, a hub for precision medicine to support precision medicine efforts across the country in the future. We did mention that we will have a biobank, and of course, just like any research institute, we have luminaries that right now are members of our scientific council, and the chair of our scientific council is Professor Achilleas Ravanis, who is also, of course, a scientist at Forth. As I mentioned, Part of this park is the education and training facilities that will house education programs in collaboration with research institutes and universities in Greece and elsewhere. We have a beautiful new auditorium, 324 seats, but more than that, we have individual classrooms and meeting rooms and press rooms and interview rooms that can certainly house workshops, seminars, but also standing educational programs, pre-grad and post-grad with affiliated universities and academic centers. This is not just plans. Actually, we have a beautiful building that is already up. You can see here the frame. So the frame of the building is complete, and we're now in the phase of constructing the interior. You can see the similarity, of course, with the images I showed you at the beginning. We want to present our two leaders, Konstantinos Pedafragas, who is the CEO of the LPEN Group, and Theodore Trifon, who is the president of the Panhellenic Union of Pharmaceutical Industries, as well as the co-CEO of the LPEN Group. And this is the team that leads the park. Our project leader is Eleni Pedafraga, who is a member of the board of LPEN and an outstanding visionary leader. Dr. Kyriaki Bergidzi, I already referred to her as the scientific director of the Educational Research Center and an essential member of the team who really plans what we're doing for everything, for every single component of the park. We are fortunate to have signed up Dr. Iliopoulos, a good friend of mine and collaborator from many years back, as the chair of the scientific board of the park. And in that scientific board, we've already started recruiting people. One of the first recruits is Dr. Katsanis, again, a good friend and collaborator from the United States, also in the area of precision medicine. Professor Achillas Ravans already mentioned his name. He's the chair of the Scientific Advisory Committee for the Research Institute, a good friend and collaborator for many years. And Dr. Tsutsu is our designated veterinarian, and again, an outstanding member of the team who plans our pre-CRO activities, helps me out with the Research Institute, and of course, will run the vivarium. Let me take a few minutes of your time to show you how the center will look in the future. Allow me to play this video, which will have to go to YouTube, and hopefully we'll play it right now. Can you see it and hear it?
Yes, we can.
So you can see here the education center, the incubator. We are, as I said before, in the middle between Picarium and Spada. This is the front part of the park. This is going to be the restaurant on the top, the main offices in front of the Research Institute. Here is the entrance. You can see the Research Institute and the incubator. This is the back side where there's going to be activities. The atrium as you get in. The way back to the labs. This is the auditorium. Then the backside again, where we're going to have activities. There's this huge staircase that people can sit, and of course, when we have festivals and workshops, it will be one of the main areas where presentations will take place. So I'll finish up here. I want to thank for the opportunity to present to you our park. And again, I hope that many of you will visit it, and some of you, I certainly hope, will end up working there. Thank you so much.
Thank you, Professor Sotakis. I certainly look forward for an opportunity to do research in that beautiful center that I think will be a jewel in the research capabilities of Greece and an innovation incubator to be a bit in the theme of our today's session. Thank you very much.
Very welcome.
We will move now to the next speaker, Professor Apostolos Stasiopoulos, who is a professor of surgery in the Stony Brook University, who also couldn't be with us, unfortunately, today physically, but is online, and he will be talking about how can we measure the quality of surgical care.
Good morning, everyone, and thank you for the very kind invitation. I wish I were there. Aristotle is my alma mater, and I would prefer to give this presentation live there rather than speaking at 3 o'clock in the morning out of New York. But I will do my best to cover a very broad topic in about 10 minutes. So, use of quality metrics to target quality improvement is kind of a standard right now across the US healthcare system. And the vast majority of the performance data is used by physicians and hospitals to launch performance improvement projects that are designed to optimize both healthcare delivery, but also healthcare outcomes. There is a number of different measures and a number of different databases that are being utilized. I'm going to try and put a little bit of an order on these. Some of these measures are structural. Essentially, what they measure is what's the system's capacity, the systems in present, and processes that are designed to provide high quality care. Some of these metrics are procedure volume in a certain institution, the presence of subspecialty, training amongst physicians, the nurse-to-bed ratios, some of the specific amenities such as closed intensive care units, the presence of robotic rooms, and the whole 9 yards. There are process measures. Process measures indicate what a provider does to maintain or to improve patient health. These process measures check whether a physician did the right thing for a patient-specific condition. And some of these are like the use of antibiotics around the time of surgery or the use of DVT prophylaxis in the perioperative period. Those process measures don't indicate either whether a patient's health will improve under the particular physician's care. And finally, the outcome measures, which are the most commonly used. Outcome measures reflect the impact that the healthcare service or intervention has on the health status of the patient. These measures for surgery are usually 30-day mortality and morbidity rates, length of stay after an intervention, readmission rates, patient satisfaction, health-related quality of life, cost effectiveness, use of resources. By using validated risk-adjusted models that take into account the patient's severity of illness and the different patient populations that exist across different institutions, can provide some data that can be reliably utilized to create a sustainable culture of patient safety. So these are the different types of metrics and also the different types of databases that are being utilized. If you ask surgeons, they will tell you that they can accurately rate the skill of their colleagues just by observing their technique in the operating room, such as in this very famous painting by Thomas Eakins. But in reality, most of the surgical quality of care is being measured in quality database. The most widely disseminated one is NSQIP, or the National Surgical Quality Improvement Program. This was originally originated in the Veterans Administration hospitals in the US, but since 2004, the American College of Surgeons has adopted it as the primary database for surgical quality. The outcomes are assessed at 30-day intervals after the index surgery, either inpatient or outpatient. It's highly standardized and validated data definitions, and there are very well-trained abstractors that are collecting these data and provide advanced data analytics for risk adjustment so that we have a reliable comparison between patient samples. NSQIP provides data-driven tools for clinical decision-making, and the platform releases 4 times a year reports that are risk adjusted and allow for different institutions to assess how they perform in comparison to other institutions in the country. In addition, we have individual surgeon data that is available, can be downloaded, and can be communicated to the individual surgeons so that they can see how their performance is in comparison to their peers. This is what an ISQIP report looks like. The color identifies areas where a certain program has an exemplary performance. If you are on the green side, or a performance in a specific metric that needs attention and improvement efforts. These results can be trended over a period of time so that they allow assessment of if specific processes that are being put in place can really have an impact on patient outcomes. A different database is the Agency for Healthcare Research and Quality. This particular database focuses on potential in-hospital complications and adverse events following surgeries, such as iatrogenic pneumothorax, central line infection, development of pressure ulcers, and so forth. This is what a report like that looks, and there are some quality indicators divided in different categories that can be trended over time for improvement purposes. Vision is another database. I'm not going to bother you more with that, but we are collecting data on all of these databases so that we can paint the most accurate picture of specific elements of our healthcare delivery so that we can design the appropriate interventions for improvement purposes. There are service-specific quality databases, such as this, the Society for Thoracic Surgeons Adult Cardiac Surgery and Thoracic Surgery database. These are being utilized to assess globally a program's performance, and it has this star category, such as where a 2-star performance is as expected, a single-star performance is worse than expected, and a 3-star performance is above, is better than expected. This has sometimes monetary implications in terms of how much an institution is being reimbursed for a specific procedure. The Vascular Quality Initiative, which tracks performance on vascular disease, has the additional ability to drill down to very specific metrics to vascular surgery and provide clear performance metrics that are specialty specific. So how do we utilize this data to improve outcomes and performance? In 2015, I took over the role of the surgeon champion for the institution in an ISQIP, and we set our goals to reduce surgical complications by 20%, specifically surgical site infections, myocardial complications, urinary tract infections. These were all areas where performance was deemed to be suboptimal. We developed a team of individuals from surgery, from information technology, infection control, quality and analytics, and coding. And we developed what we call the war room, where we designed interventions and implementation of these interventions across the system. One of the things that we focused our attention on is the appropriate capture of the patient risk profile, and that took quite an effort to standardize the way that we're capturing certain elements of the patient's risk factors, such as the functional status. That is something that has been proven to be an important element on patient perioperative risk. We had an issue with prolonged ventilation and unplanned reintubations after surgery. We optimized our communication with our ICU attendants to expedite extubation of patients within 48 hours from surgery. And we developed programs that standardized reversal of neuromuscular blockade, and that dropped dramatically the rate of unplanned reintubation in the immediate postoperative period. When it came to cardiac complications, one of the elements that appear to have the most impact is this digital communication tool between surgeons and cardiologists that allowed preoperative assessment of patients' care, optimization of their perioperative course, and of course, management of their perioperative anticoagulation, antiplatelet regimen, so that it minimized bleeding complications, but it protected the patient's myocardial function. Using the NSQIP risk calculator score, we identified patients that were of prohibitive risk of surgery, and we provided them with alternative treatments. When it came to urinary tract infections, one of the common themes was unnecessary use of Foley catheters, prolonged placement of Foley catheters that resulted in urinary tract infections. We focused our efforts here on educating a select group of operating room nurses on Foley catheter insertion, appropriate technique. We developed a standardized protocol for nurse-driven Foley catheter removal, and we monitored that real time using some of our information technology tools. That particular live monitoring allowed us to address deviations from the standards of care that we had already set. One of the areas where we had the most impact was surgical site infections. Surgical site infections is one of the most common complications and one that costs approximately $3.5 billion annually in the United States. By allowing an accurate classification of the surgical wound, we embarked on using the checklist bundle, as you see here, the preoperative preparation of the patient with Hibiclin sours, the intraoperative management of surgical site protection using fascial wound protectors, appropriate selection of antibiotics and a standardized redosing program, and then postoperatively management of the sterile dressing and educating nurses and patients on how to care for the surgical wound in the postoperative and the post-discharge period. These were documented in the EMR. You can see here our standardized redosing and the antibiotic regimen that is now in use across the institution and across different subspecialties. Finally, for cases that were contaminated or clean contaminated, we encourage surgeons to change gowns and gloves and to use instruments that were previously unused so that we minimize superficial site infection for these cases. So what we achieved by organizing all of these efforts, first of all, was a very broad surgeon and anesthesiologist engagement in these processes. We witnessed significant decrease in perioperative mortality. We have been in the best decile in the country for over 7 years now. We decreased unplanned reintubation, pneumonia, urinary tract infections, renal failure, and sepsis to very measurable percentages. But more importantly, we have been able to promote a culture of safety among surgeons, residents, nurses, and OR staff that focuses on improvement processes and celebrates success. I would like to thank once again the organizers for their very kind invitation. Thank you.
Thank you very much for your talk. Very interesting. And we see how sometimes just measuring something can help us change the way we think about it and try to change it. Thank you very much. Then now we will go to the next speaker. I would first like to make an appeal on both our two last speakers to be on time because we're a bit over our own time. So I welcome Professor Dimitrios Karousis. He's a professor of neurology at the Hebrew University in Jerusalem, and he will talk about stem cell therapies.
Thank you very much, and good morning to everyone. I want to congratulate you and the whole effort. This is a unique effort to stabilize, to produce a brain tank from all over the world of great scientists and to collaborate, and I think this is a great, great initiative. I'm going to give you some overview, very, very short, just some ideas about the future of regenerative medicine. And we know that especially in neurology and neurological diseases, regenerative medicine should and is the future. And cell therapy is, of course, the central part. And we are happy that our group is so moving forward this whole project of cell therapies in neurological diseases. What is the unmet need in neurological diseases in general? First of all, that there is no efficient way today for regeneration, neuroregeneration, when something is lost in the brain or in the spinal cord is lost. And we know it from the stroke and other situations, from chronic degenerative diseases, Alzheimer's, Parkinson's, spinal injury, multiple sclerosis in the progressive form, ALS and everything. The second one, which is still an unmet need, is that there is always a compartmentalized and slow inflammation ongoing in many neuroinflammatory diseases. And this is involved even in degenerative diseases like Alzheimer's or even Parkinson's. So the principle of regenerative medicine should be to try to produce cell replacement and regeneration. And the only and the main way that you can do it is by stem cells to produce neurotrophic factors in order to survive, to rescue the damaged cells, and also to induce neuroprotection. But also those stem cells can be used as Trojan horses, we know it in the Greek tradition, and then they can produce local immunomodulation because cell therapy and especially stem cells have a triple way of function. They do not only replace cells that are damaged, they do not only produce neurotrophic and neuroprotective elements and factors that they can rescue the damaged cells, but they have also strong down-regulating properties of the inflammation, immunomodulatory properties. And that's why they can suppress this slow inflammation, which is involved in many degenerative diseases. And there are two major types of stem cells, with addition of the third one, the induced pluripotent stem cells that can be genetically produced. But in the right side, we have, in the left side, we have the classical, the prototype of stem cells, which is the embryonic stem cells. We know that an embryo, every body is produced by these embryonic stem cells, which are completely multipotent. And in the right side, we have also adult stem cells. Without them, we cannot survive even one day. These are the cells that produce and then rescue us from any damage from the skin to the brain. And when we're talking about the adult stem cells, the biggest source of any stem cells in our adult life is the bone marrow. In the bone marrow, there are two populations. The first one is the hematopoietic stem cells. I will not talk a lot about this, but still, hematopoietic stem cells can reproduce the whole immune system. So when they produce the new immune system, they can suppress autoimmune conditions and inflammatory conditions. And we have seen it 30 years ago in animal models, several animal models, that if we replace the immune system by hematopoietic stem cells, we can produce a long-standing tolerance. And I'm very happy that the first clinical trial with the hematopoietic stem cells, there are about 23 until now, in diseases like multiple sclerosis, in order to suppress this inflammation and stop the autoimmune reaction, came by a collaboration with my Greek colleagues from Thessaloniki, with Professor Fassas and Kimiskidis, and they did this in collaboration after the animal studies of our group, showing impressive effects in the suppression of the multiple sclerosis. Today, it is widely accepted that we can have a much better effect than any other medication for multiple sclerosis, showing that this concept of hematopoietic stem cell transplantation could be relevant only for the inflammatory diseases, where the inflammation is the major part in neurological diseases. But the other part is, of course, the regeneration. And for regeneration, because we cannot use, for many technical reasons and also ethical reasons, we cannot use embryonic stem cells. We used some adult type of stem cells, again from the bone marrow, but this time the mesenchymal stem cells. Only 1% of the bone marrow stem cells are mesenchymal stem cells. And of course, the default action is to produce cells of the mesodermal origin. But under certain ways of culture and culture media, we can drive them in order to produce transdifferentiation to neuronal lineages to produce neuroprotective factors, and to produce local immunomodulation. So it's a very, very good way. And if we inject them to paralyzed animals, as we see in the left video, then when we inject those animals which are paralyzed with those mesenchymal stem cells, they are almost completely healthy, especially when we inject those cells directly into the cerebrospinal fluid, so they go directly to the brain and the spinal cord that is damaged. Then from the animal models, we came from the bench to the bedside, and there are indeed many, many trials, not only in our centers, but the last 15 years, there are more than 500, and I believe that now maybe it is close to 1,000 clinical trials in neurological diseases with mesenchymal and other stem cells, most of them with mesenchymal stem cells because of these practical advantages of the use of mesenchymal stem cells. They can be obtained from the patient, so we do not need a donor. They can be easily cultured and expanded and injected autologously. There is no need for any immunosuppression, and they carry much less dangers for malignant transformation. So the use of mesenchymal stem cells was shown in severe diseases like the Parkinson plus syndrome, what is called multi-system atrophy, some years ago, so that there is a very good suppression of the progression of the disease. Also in stroke, many studies show that even after 6 months after an ischemic event of the brain, the stroke, there is almost in all patients a very good recovery of the area of the lesion of the stroke. In ALS, many studies, including in our center, show that we can triple the new neurons that are damaged in the area of the injection of the stem cells. And also in spinal injury. In spinal injury, injecting those mesenchymal stem cells into the cerebrospinal fluid produced in all of the patients improvement in some of the function, especially the urinary function and the sensory function. In our center, we have performed until in the last at least 12 years, we have performed 6 clinical trials with stem cells in 2 different diseases, in multiple sclerosis and in ALS. First of all, in ALS, the first study in 2010, again in collaboration with Greek scientists, with Professor Karageorgiou in Athens, we saw that we can stabilize the disease without significant side effects. Then we enhanced those stem cells because ALS is a very, very Lou Gehrig disease, a very severe disease. And by producing this enhancement of the stem cells, that they produce 10 times more growth factors, then we had a much better effect and about 50% suppression of the progression of the disease in all of the patients. We can see it in another way. The improvement, those are all the patients in green color. We see that in the respiratory function or in the total score, there was an improvement. And even if we continue the treatment for 4 years, then we can see that these additional injections of the stem cells can stabilize the patients for long periods of time. Now, in multiple sclerosis, which is my main field, because I'm leading the Center of Multiple Sclerosis in Israel, we have shown in 2010 that we can reduce the lesions of the brain in the patients with multiple sclerosis with a good safety profile. And then we made a double-blind study published 1 year ago in the Brain Journal, in which we compared for the first time in a double-blind way with placebo. So we took the stem cells from the bone marrow of the patients and we inject them into the cerebrospinal fluid or placebo, or intravenously. So we compared the 3 groups, and we found that in the group injected intrathecally with the mesenchymal stem cells, almost 80% of the patients were either improved or stable after 1 year of the treatment. And more impressively, in the right side, we see that the functional MRI, which shows recovery of the functional motor networks, there was improvement in the patients treated with mesenchymal stem cells intrathecally. Even the relapses, which is an indicator of the inflammatory activity of the multiple sclerosis, in the green bar there, we see what is an impressive reduction of all the activity of the disease, both in the MRI, in the right side, and in the clinically relapses. And the last was what happens with the degeneration. And this is a very, very lately published paper where we checked 6 months after the treatment in the cerebrospinal fluid what happens with the neurofilaments, which is the main biomarker of neurodegeneration. And we found that in the intrathecally treated patients with mesenchymal stem cells, there is a 3 times reduction in the neurofilament levels. And if we check into the CSF, then we see that there is, in most of the patients, almost 90% of the patients, there were more than 50% reduction in the levels of neurofilaments, indicating that we stop the process of degeneration. And with this, I will show you also 2 slides of the future, because in order to produce new technology and to improve this technology, we try new ways of administration in animal first, by nasal administration of those stem cells with better results than the intrathecal injection. And we also neuralize those stem cells, producing neural progenitors. When we produce neural progenitors, we have about 2 times more effect, again, in the animal models of neuroinflammatory diseases like multiple sclerosis. And I want to thank all the collaborators. We're a big group of people involved in Israel. We have collaboration with 3 centers in the United States, with 2 centers in Greece, and I hope that this will expand more, because this is probably the future in neurological diseases. Thank you very much.
Thank you very much for your excellent talk about the future of therapy in neurology, and also for being very on time and so on. And then I would like to welcome our last speaker. He's a student of biomedical engineering in Bronx Science, and he will present from the perspective of Hellenic youth and also a project that they are making. And please try to be short and on time, because we're eating a lot of time from the next session. Thank you.
Okay, definitely. Okay, today I'd like to present 2 topics mostly, which is the artificially intelligent robots in medicine and also Hellenic youth for robotics in medicine. So before I go on, I'd like to introduce 2 terms mostly, which is AI. What is AI? It's artificial intelligence is the simulation of human intelligence processes by machines, especially computer systems. What is a robot? A robot is a type of automated machine that can execute specific tasks with little or no human intervention and with speed and precision. And AI-controlled robotics, it's an artificial intelligence is used in robotic control to make it able to process and adapt to its surroundings. So before going on to the medical side, I'd like to introduce 4 different artificial intelligent robots that have become major parts of their respective industries. First, with the Miso Robotics Flippy, which acts as a chef, mostly in fast food restaurants, that is cost-effective and more efficient than a human chef. And next, which is more software-oriented, is the Hanson Robotics Sophia, which offers deep conversations as it's the most advanced chatbot in the world. And third, the Sea Machines Machine Odyssey, which is a completely automated boat that's used to survey the ocean and wildlife for any data that's needed, and that's without having to risk a single human life. And lastly, using a technology most of you would be familiar with, which is a robotic arm, but it equipped it with sensors and cameras in order to make it more safe within the manufacturing field whenever a human's near it. And first, before going on to the dangers, I'd like to introduce that robotics for medicine hasn't really broken into the field, mostly because it cannot guarantee the safety of the human patient, which is a big problem. And these are 4 specific dangers that I thought would be the most important, which is AI always can and will make mistakes, no matter how efficient or how much you train it. And secondly, an AI's goal will always remain the same, to keep a patient safe and healthy. However, the methods it takes to achieve this goal can over time evolve to become malicious or accidentally harm the human. And I'm more on the robotic side. The batteries used within robots, such as lithium-ion batteries, which is within everything, like computers, phones, anything around us. They're extremely flammable and dangerous, especially when tampered with. And what I view to be the most important reason why it's not used for medicine and robotics is robots interacting with younger or older patients, especially in delicate parts of their body, can harm them permanently or cause pain to them if it applies too much pressure. And these are 4 solutions that I thought would fix, which is combining both machine learning aspect and the human evaluation in order to guarantee the safety to a higher degree, because a human can go in and determine what a robot needs to fix. And also for the second Second solution, which can only be done after the original pilot testing, would be training the AI with better data that it gets as it actually runs and helps humans, and see where it made mistakes and where it can become more efficient. And more on the robotic side is, of course, increased installation of wires, introduction of automatic emergency shutoff options, or shutoff options that can be controlled by doctors or trained professionals, and the use of lithium iron phosphate batteries, which are much safer than the regular lithium ion batteries. And also, a major topic that I've been researching into and creating robots on is the use of series elastic actuation. And what is series elastic actuation? It acts as a mechanical and physical failsafe set in place if the AI used in the robot ever fails or the computer ever fails. It acts as a way to guarantee the safety of the human subject or other delicate objects by stopping when it's acceptable to making mistakes. It offers extreme flexibility with shock tolerance and interaction with the environment, making it more versatile than our own hands or body. And it is already used within the medical field. However, it should be introduced to the autonomous side more in order to make it more feasible and safe. First, I have a video, which is this introduction. So this is a wooden stick that breaks at like the slightest force, and it stops and starts to pull onto the green rubber band, which I use as the elastic component instead, which proves that it's safe to be used, especially with human skin and patient. Demonstration. Okay, and the past examples of this and medical innovations would be the Maestro exoskeleton, which is mostly used for rehabilitation, and it provides assisted movement to multiple degrees of freedom for the hand to allow human patients to regain motor control of the thumb, index, and middle fingers. And also the UT Harmony exoskeleton, which was made by the University of Texas, which assists with upper body movements by handling all of the patient's weight and passively assisting the user's in tendon movement on 14 axes. And both robots have a 100% success rate, and it can be attributed to the series elastic actuation it uses because it guarantees the safety of all the testing subjects it used. And these are the implications of such robots, which would be humanoid robots can be nurses for older or paralyzed patients in case they're unable to afford a human nurse to take care of them 24/7 and they don't have the family who are able to do so. And also, they can be assistants during surgery, which are able to undergo any task that a human would be able to, or assist a doctor within the office as a nurse practitioner. And lastly, and which also could be most importantly, is that humanoid robots can become first responders to assist people in dire need because of their limitless knowledge, along with their ability to conduct any medical procedure on site or anywhere. And lastly, this is the Hellenic Youth in Robotics for Medicine. Okay, I'm William Azidis. I'm one of the head constructors for my school's robotics team, which competes nationally, and every year we build different robots. And robotics, especially robotics within New York City, is attracting many, and the majority of Hellenic youths, with the most popular field being nowadays computer science, which are the people who actually build the artificial intelligences I was talking about throughout this. And me and a few associates are currently developing a nonprofit organization of Hellenic youth to try and develop robots and AI for medical purposes or other technologies. And even though it's currently in the development stages, we've had multiple people from different schools and associations agree in helping us, and we're now trying to expand into Greece. And as inspiration for the nonprofit and this whole presentation, I truly believe Hellenic youth is the future.
Thank you very much, William. And perhaps you can find some collaborators here in this Aristotle Medical Forum. And with this, I would like to thank all of the people that came, all the speakers that spoke, and the people also in the next session that took with great patience the delays, and conclude this session. And thank you very much.
Καλημέρα σας, καλώς ορίσατε. Good morning, welcome. My name is Stefanos Kallis. I'm professor of medicine at Harvard Medical School, also professor in the School of Public Health at Harvard. It's my honor and privilege to welcome you to the next session on pandemic response. Since we're behind on time, we'll go directly to our speakers, and I'm very pleased to welcome my colleague from the Greek National Public Health Organization, Professor Theoklis Zaoutis, who was formerly a professor at UPenn in the States and now is here full-time in Athens. Professor Zaoutis, welcome.
Thank you very much, Stefan. I don't know, am I still a member of the diaspora? I guess now that I'm permanently in Greece, I'm no longer a member of the diaspora, but proudly still affiliated as emeritus professor with the University of Pennsylvania. I was asked to speak about the next pandemic and some of the lessons learned. I know there's another speaker who'll be speaking about the lessons learned. I have no slides today. The COVID-19 pandemic is the most important lesson in public health that we have received in the last 100 years, and we really need to think about taking advantage of it in order to address future public health emergencies and pandemics. There is something called the panic neglect cycle, which is something we need to avoid. The panic neglect cycle is the habit of underinvesting or paying inadequate attention upfront to public health infrastructure and functions needed to prevent, identify, contain, and respond to infectious disease outbreaks, and then responding with panic when they happen. Is another pandemic inevitable? More than 6 out of every 10 infectious diseases originated in animals and jumped to humans, and the risk has been increasing over the last 20 years. The reason I'm building up the animal story is because that's where the next pandemic is likely to come from. Every year, the risk increases more. Pandemic prevention needs to include the need to have better systems to protect nature. In studies of drivers of zoonotic diseases, the risk has been highest when human exploitation and habitat destruction threatened wild animals. When we hunt and occupy wild animals' natural homes or sell wild animals in markets, such as the markets in Wuhan, they experience great stress, which makes them more likely to get infected and produce higher numbers of viruses. This leads to greater viral shedding, which is the expulsion and release of virus-carrying excretions. Being around stressed, sick animals or eating them exposes humans to a greater chance of catching a virus. The possibility of virus spillover is also higher between humans and animal species that have similar DNA or have lived together over time, such as pigs or livestock. And we well know that influenza is common in the swine species. Environmental health and slowing climate change is an important factor in reducing the risk of the next pandemic and other emerging infectious diseases. Because of increasing temperatures, animals are migrating from the south to the north. When animals migrate and they change their territory, they come in contact with other animals, as I mentioned above, and that they've never been in contact with before, and they exchange viruses just as they exchange viruses with all of us. So what do we have to do to be better prepared if we believe the next pandemic is inevitable? Pandemic preparedness begins with strengthening public health infrastructures locally and globally, which includes increases in public health funding, infectious disease experts detecting outbreaks of a new disease early and addressing them early while they're small is key to preventing a larger emergency. Much of the preparedness burden lies in the hands of public health institutions, but the public can play a vital role. If we think about which patients, which persons were most affected by COVID-19, there were people with chronic, non-communicable conditions, chronic lung disease, chronic heart disease, cancer, other immunocompromising conditions. If we want to reduce the impact of infectious diseases and reduce the impact of future pandemics, we need to do a better job of preventing and treating chronic medical conditions. With this, and I know my colleague here is interested in this, comes healthy lifestyle and wellness. The patients, even prior to COVID-19, Influenza affected people with chronic conditions and the elderly. All the viral infections that we've encountered, whether endemic or epidemic, affect that population. And we need to think about focusing our efforts on lifestyle and preventing chronic medical conditions. We now have better tools to address infectious diseases than we've ever had. If you think about how quickly we identified the genome of coronavirus 19, but we are also more vulnerable than ever, partly because of a widespread trust between communities, governments, and healthcare systems. Boy, did COVID-19 ever expose that level of mistrust. Pandemic misinformation can influence people's motivations, beliefs, and decision-making concerning their health, politics, the environment, and more. We, as scientists, and physicians, have to do a better job and be more consistent in our communication with the public. Adhere to the facts, evidence, and data. And I know you've all seen, whether it's in the US and Greece, the talking heads that don't base their predictions or data on facts. And engage communication expertise. We need to be better at communicating. Just because we're brilliant scientists, or some of us are brilliant scientists, not me, we need to do a better job of communicating. And increasing and improving public health awareness is an integral part of pandemic surveillance. Applying the lessons learned from the COVID-19 pandemic is therefore key to managing further public health crises, including pandemics, and to prevent the countless consequences, including lives lost, drastic effects on our healthcare systems, mental health, the economy, relationships, and careers. I'm going to switch gears just for a few minutes and talk about something called the silent pandemic. The silent pandemic is the pandemic that is brewing and has brewed underneath the COVID-19 pandemic. The silent pandemic refers to the pandemic of antibiotic resistance. The expectation is that 10 million people will die annually in the year 2050 due to antibiotic resistance. That's many more than lost lives during pandemics. Why the COVID-19 pandemic has created the perfect storm for the silent pandemic of antibiotic resistance. Why? Where are the resistant bacteria found? They're found in hospitals and intensive care units. So what have we done? We've put more hospitals in more intensive care units. Hospital-acquired infections are related to devices that we put into patients, tubes, catheters, breathing tubes. More of those for longer periods of time in more patients in stressed healthcare systems. Therefore, we have had an epidemic of healthcare-acquired infections. Data from the United States CDC suggests a 50% increase in healthcare-acquired infections in the US during the COVID-19 pandemic. And I think there are data now globally about this. And the bugs causing these healthcare-acquired infections are resistant to antibiotics. The other piece of the perfect storm is every patient with COVID-19 got an antibiotic, whether they needed it or not. Because, of course, as physicians, we treat ourselves. We don't necessarily treat our patients. So the majority of patients, either in the community or in the hospital, received an antibiotic. So more patients in the hospital, more tubes, more catheters, longer periods of time, stress systems, more antibiotics. Hence, we have this silent pandemic right now that has probably contributed significantly to the mortality of COVID-19. And therefore, I think we need to address this problem as part of addressing the COVID-19 pandemic. Thank you very much.
Thank you very much, Professor Zautis, for an excellent summary and a great presentation. Our next speaker will also give us another view of lessons learned from the pandemic, and that is Professor Panagis Galiatzos, who's joining us from Johns Hopkins University in Baltimore. Professor Galiatzos, welcome.
Excellent. Thank you so much. And you guys can hear me, just a confirmation? All right, perfect. So what I'll continue with this is a lesson, lessons learned. I'm going to call it a specific lesson learned from the COVID-19 pandemic. To some extent, for many of us who have been doing this already, we knew this was going to happen. And now let me just bring to light what this ultimately means for a healthcare system to consider as it invests in itself to really promote health and prevent disease in the 21st century. Disclosure. So this is the slide that I want to hold on for a few minutes in order to kind of digest this, right? So I'm a pulmonary critical care doctor. I've been working at the Hopkins Health System since about 2010 with a brief pause to be at the NIH in the last decade. But during my time at Hopkins has two hospitals in Baltimore City. One of the hospitals is Hopkins Bayview, and it's more of a community hospital. It's more of a reflection of the Baltimore City population it serves. And over the last 2 years, right? That's what this captures, stretching all the way back to January of 2019 to March of 2020. You see from a racial standpoint, pretty unchanged, white versus Black African-American counterparts, unchanged during those 2 years until the first 3 months of the pandemic, where you saw a surge of Black African-American patients into our intensive care units and a decline in their white counterparts. Now, I know, socioeconomic or socio-demographic variables are complex here in the United States. To some extent, race is a reasonable proxy to more complicated conversations around social factors. But this drive in a specific demographic sharing a disproportionate impact of severe COVID. Now, one pause here. These patient populations in Baltimore City have the same rates of COVID-19 diagnoses, but one population had a larger amount of severe COVID, resulting in ICU admissions. Black African-American races, meaning the minority races. So I say this because as a healthcare system, if much of the differences are driven by unjust measures, right, resulting in disparities, if these are being driven outside of the hospital walls, outside of the clinical arena, well, what is a health system meant to do? Right? What do we do? You can create the best vaccine, you can create the best steroids or interventions in order to help these patients, but that just levels the playing field in the hospital. And one of our colleagues out of Louisiana, Haywood, in their study in New England Journal of Medicine, early in the pandemic around disparities, emphasized that. When you take race into account, no differences in in-hospital mortality, but that's in-hospital. What are we doing outside of it? What can a health system begin to do to make an impact? Predating the pandemic, my colleagues and I, we created an organization out of Hopkins called Medicine for the Greater Good. Now, again, this predates the pandemic. And to some extent, I will tell you, it is a biased organization on my end. I grew up in the Greektown section of Baltimore City. I saw the power of community in its efforts to overcome many individual gaps through community efforts, right? That's the Greek spirit in us. And when I became a physician at Hopkins, I wanted to see the same, right? I wanted to create an organization that really utilized the energy, the creativity of community efforts and grassroots movements. But I didn't want it to be just the community doing it. I wanted a health system to understand how to do it. I wanted physicians to know how to work with the community. As doctors, we always preach being bedside by the patient. We should be bedside by the community to really understand their culture, their concerns, and what health means to them. We founded it in 2013, and this organization is a requirement for physicians in internal medicine at the Hopkins Bayview campus. They all have to go through this level of training. So why I say this is because we've always been doing community engagement in some capacity, working with certain social networks. Social network, its formal definition is here, and it is in essence a collection of people driven by a culture, driven by an identity. There's a free flow of conversations with this notion known as homophily. Everyone sees each other as one and the same with a mutual sense of respect and love. And for examples, we have schools, we have neighborhoods, to some extent, and faith-based organizations. So let me tell you what Medicine for the Greater Good did and the big lessons learned for our healthcare system moving forward and its investments of what we're seeing now post-pandemic. So first, our efforts with faith-based organizations. We worked with churches, mosques, synagogues way before the pandemic, and then especially during the pandemic, once it struck, March 13th of 2020, our governor in the state of Maryland, utilizing the pandemic declaration, put the state under an emergency, school shut down, public gatherings shut down, and suddenly we needed to advocate to get messaging about COVID in real time out into communities, but in a different format, right? We couldn't be out in the community. We couldn't be bedside by the community, as I said earlier. So we flipped the script and we did this virtually, as many of us are doing, as we're doing, for instance, right now. And we began to hold what are called community calls once a week. We reached out to every faith-based organization that we partner with, all the leaders, all the imams, all the rabbis, all the priests, the reverends, and we said, hey, every week you're going to get Hopkins experts coming together to answer in real time your concerns about COVID. These calls would draw about 200 to 300 spiritual leaders every week. every week, asking us important questions and letting us get a sense of an understanding of what really is plaguing them, what really is bothering them or driving a variety of disparities out in Baltimore City around COVID-19. And then we close it with a cultural humility of some spiritual reflection led by one of the spiritual leaders. And ultimately, this came together, known as our Healthy Community Partnership for the Pandemic Response. The effectiveness of this, drawing the attention, the mayor of Baltimore City reached out to us and said, we want a formal medical religious partnership using this platform where the congregations you have partnered with will ask of them to also hold vaccine sites in real time. Meaning, once the vaccines were out there, and we wanted to get that rise of the population getting vaccinated in order to see at least the numbers from severe COVID being driven down, we wanted to utilize the faith-based organizations for places of delivering the vaccines to some extent. And so they wanted us to partner in order to create these effective messages out there in real time. And we did. We led about 1,200 town halls during the pandemic. I myself conducted a little over 400, and my other colleagues, part of Medicine for the Greater Good, were out there. We were talking, we were partnering with bishops, reverends, rabbis, imams. We held these conversations about the COVID-19 pandemic, but we weren't there to give a grand rounds presentation. We weren't there to give a science lecture. We were there to discuss COVID-19 in a manner that we could translate it to the community, what was important to them, right? To me, I discuss this as like playing music. No musician goes out there and plays every single note. He knows his audience, he picks 2 or 3 notes, repeats them over and over again, suddenly you have a good song. Same thing we did here. We knew who the community was, we knew what was going to be effective to message to them, and we constructed our COVID-19 conversations under the umbrella of cultural humility so we could be effective in it. We were often given an hour to talk, we spoke for 10 minutes and listened for 15 minutes. And if you're bored, I would really emphasize watching this special captured by CBS here in America about our work with one of the imams. And this, to me, was one of the best examples. His congregation, to date, serving some of the poorest individuals in Baltimore City, has not had a loss of, and has not had a death in that congregation. They were pivotal to getting face masks out early on. We helped them out with other efforts such as food and so forth to delivery. And when the vaccines came out, I was invited to give a virtual session with him, right? And you could see all the faces on Zoom and so forth. And I remember talking about the vaccine. He follows up by quoting something out of the Quran. And you saw, whoever had their camera on, you saw their heads nod in agreement of this is the right thing to do, using science as part of their culture in order to preserve their own identity. How successful were we? We partnered with 82 faith-based organizations, a little over 21,000 Baltimore City citizens that are congregants. Through the School of Public Health at Johns Hopkins, we formally surveyed every single individual getting vaccines on site, and 92% of them were vaccinated. And these were efforts done because of our partnership, because of the medical messaging. Not that they had trust in us, but they had trust in their spiritual leaders who, being our proxy, trusted us. 92% of these vulnerable populations, these were predominantly minorities, Black, African American, and a variety of Hispanic, Latino, where I had to utilize my Spanish as much as I could in order to help promote this messaging. Next, we moved into the schools, and this is where I'll close it for a few last slides. We created a curriculum for the Baltimore City schools. Granted, it did reach a little bit of an international status as well, but here we trained over 200 physicians to know how to go and talk to kids K through 12, learning the pedagogy appropriately to message COVID-19. We made it clear everyone has a hand in ending the pandemic regardless of age. If you're not catching it, you're helping us. This is one story that I really always like to emphasize. A student from Montana, Native American, 80% of his elders died from COVID. He reached out to us in order to teach the youth how to help the elders survive COVID-19. It's a beautiful story from the Chippewa tribe. From the Baltimore City schools, 38 schools that we partnered with, 38 schools, 12 years and older, because that was where our data was collected, where the vaccine was approved. Close to 60% of the students were vaccinated through these efforts. And again, I'm using vaccine as a reasonable proxy towards all of this, but this is the lesson learned. And thank you for my colleague from Penn who kind of planted the seed, right? And so from my standpoint, the big lessons learned out of this is somewhat of a Greek tragedy, right? If you think about it, we have the tools to end the pandemic. We know how to not catch it. We know how to not spread it. We know how to stop severe COVID. And still we're finding a community that doesn't accept this. And from my standpoint, it's because science, in some way, shape, or form, has lost its notion to be a cultural relevant member. It has become disconnected. And from that standpoint, we have to recognize that our scientific objective facts, our researches, they're not gospel. They're not the Torah. They're not the Quran. They don't have a cultural purpose for many of the people that we want to help. And so from that standpoint, we really need to do better to focus of how to work with the community to be medical messengers in real time to promote health and prevent disease in order to make medicine a public trust. And I'll close with this. Back in 2016, 2017, I had the privilege of working with Dr. Anthony Fauci at the NIH with our Ebola surge of patients that we saw at the NIH Clinical Center. In March of 2020, he gave a lecture, which was quoted in the Washington Post, about his lessons learned from the AIDS epidemic. And he said, public health messaging needs to be at the level of the community. You need to go into the community and talk with them side by side so you can understand their struggles and successes in real time. In the 21st century, that's what every health system, in my belief, needs to invest in. And sure enough, at Hopkins, we've invested close to $20 million of just that, of medical messaging. So for the next public health crisis, we are prepared. So thank you so much, and over to you.
Thank you again, Professor Galiatzos. Appreciate it. Professor Mocielos had an unexpected conflict. He's unable to join us. So if we can ask our next speaker, Dr. Natalia Linou, to join us, also virtually from Boston. There's Natalia. It's 3 o'clock in the morning, but both you and Panagis look good for 3 o'clock. So Natalia, I think the last talk is a good segue for yours. And Natalia is the executive director of the FXB Center for Human Rights at the Harvard Chan School of Public Health. Welcome, Natalia.
Thank you so much. And you are correct. The previous presentation is very much a good segue to my topic. So my topic is health equity in the time of COVID. And, you know, for a center that focuses on health and human rights, we have been thinking about inequities in health more broadly for the last 30 years where the center has been around. So let me begin by basically saying that who gets sick, who dies, and who suffers from the long-term socioeconomic consequences during and after a pandemic is rooted in how we structure our societies, our laws, our policies, and our governance mechanisms. And as the first speaker said, increasingly, as we internationally address some of the crises like climate change, which contribute to zoonosis. So for those who are not social epidemiologists, you probably have heard the term the social determinants of health. That basically says that a lot of what shapes our health and our well-being happens outside of just the healthcare system. It happens outside of our hospitals, as the previous two presentations has highlighted. It happens in our neighborhoods, in our schools. But even that, there's an opportunity to step back and say, why are we having unequal neighborhoods? Why are we having schools that serve some communities better than others? And fundamentally, the root cause that I want to talk about today is about discrimination around different forms. You know, we heard a little bit in the previous presentation along race and racism. That is something that my center works a lot, but also sexism, ableism, classism are all important to think about. So when we think about discrimination and COVID, which is central to health equity around COVID during and after, I have kind of grouped it into 3 buckets that our center has thought about. So the public health bucket basically says that whether you're looking at the US or Norway or Brazil or even Greece, there are stark inequities in mortality and morbidity rates between different groups by race and ethnicity. And you know, in the United States, that is the Black communities, indigenous communities, even some Latinx communities fared a lot worse. In Greece and in other parts of Europe, migrants and refugees fared a lot worse. In Norway, which you know we all imagine to be sort of a very egalitarian community, Somali communities fared a lot worse. And what's important here, and I'll stress that in my next slides too, it's not that it's a genetic reason. We're faring worse because of the way that we have structured our societies to allow discrimination to impact health, healthcare systems, but also health and well-being more broadly. The human rights frame is slightly different. Taking from a legal perspective in human rights, what we saw throughout this pandemic is reports of groups being harassed, disproportionate surveillance, or even closures around, say, Roma encampments in Europe or refugee encampments, really restricting the rights of movement of certain people, disproportionately surveilling, certain folks who were already being greater impacted. And this is where surveillance, policing, and the broader laws around, what are the powers of public health really came to bear. And, the evidence is that we didn't all experience COVID in the same way, and it did spark human rights violations across the globe. And some authoritarian governments took this as an opportunity to instill more authoritarian regimes. There were spikes in xenophobia that allowed sort of impunity around human rights violations. So what I want to stress here, as the medical community, it's really important to really be aware of these human rights violations, because fundamentally those shape well-being, including mental health, for the future. And finally, all of us can agree that COVID is not simply a public health crisis, it's also a socioeconomic crisis. And we have seen the uneven economic impact, not only by race and ethnicity, for example, in the United States, but also by gender, women leaving the workforce at disproportionate numbers in order to take on caregiving roles. So, recognizing that without explicit attention to equity, COVID-19 will exacerbate long-term inequalities. We knew from before COVID that poverty and inequality leads to poor health outcomes. Now, if we know that certain groups are being pushed into poverty disproportionately, then serious health conditions beyond COVID will also need to be, addressed. So this slide is a really important one, and it's one that I use when we talk to the U.S. context, that it's racism and not race. But the analogy is the same. If you're seeing disproportionate rates of COVID, say among the Roma in Greece, it's not because of some genetic predisposition. It's because of how we allow our societies to not support a certain group. And, in the center, I have governance failures, but you can think about all types of governance failures. The economic and occupational health inequities, for example, in COVID, there was an overrepresentation of racial and ethnic minorities among the poor, and therefore among precarious workers, whether you're thinking about India and, the informal sector and people of, quote unquote, lower caste being, subjected to not being able to work from home, or in other parts of the world. There has always been a patterning. So those people who are facing economic injustice and occupational health inequities are more likely to face COVID and therefore be disproportionately impacted. It's not because of their genes, it's not because of their behavior in the traditional sense. They don't have a choice to work from home like you or I might. Similarly, the environmental health and housing inequities, the research from Harvard colleagues showed that air pollution exacerbates COVID-19. Inadequate access to healthcare and social protection for some groups, especially undocumented or immigrants in some countries, they literally did not have access to the same care that others did. And finally, this idea of political exclusion, xenophobia, and street-sanctioned violence. We know that we often talk about mistrust, communities mistrusting institutions, but it's because we haven't created our institutions in a way that are trustworthy. And I really appreciated the previous conversation talking about how we communicate, but beyond that, also how we police, how we surveil, how we partner. So what can be done? A lot of us who work on health inequities spent the first year or two of the COVID pandemic really documenting these health inequities, but that can be overwhelming. Documenting inequities, 3 times higher rates of COVID among, migrants and refugees in Greece, or among Roma, 5 times higher in some communities in the US among indigenous, and it can be overwhelming to simply document, but there is a lot that can be done. And I'm proud that the FXB Center at Harvard partnered with the World Health Organization and other UN agencies to have a series of consultations around the future and how could we embed and address some of these structural racial and ethnicity-based discrimination issues into future planning, recovery, to better prepare us for the next pandemic. Because we know from HIV, we know from other pandemics that these inequities exist and they are not inevitable. They are a policy choice. So there is stuff that we can be doing to think about the way we structure our societies. And, we published a large report that you can find on the WHO website in English, and I think French and Spanish too. And also a very short piece in Nature Communications just came out highlighting that, three strategies that I'll spend just 2 minutes describing given our time constraints. But basically, we describe opportunities around investments that explicitly focus racial and ethnic discrimination, interventions that support delivery of universal services, but to geographies where you have compounding and intersecting drivers of exclusion and marginalization, and then some sort of cross-cutting enablers. So the report goes into each of these in a lot of detail, and I don't want to bore you by reading through them, but I think it's important to recognize that these questions around why certain groups are faring worse are universal. Whether you are a doctor in Greece, whether you're a doctor in the US, whether you're a public health professional in India or in Zimbabwe, there are certain groups in your community that are faring worse. And it's easy to put the blame or the responsibility on those individuals to say, well, they're not coming to be vaccinated, or, well, they're, eating without masks in public. But fundamentally, we know that a lot of those choices to work in person versus remotely, to have access to high quality masks versus not, are because of the structures and the economic inequities that exist. So there are some ways to explicitly tackle racial and ethnicity-based discrimination, and those people who work in human rights really talk about adopting special measures, addressing law enforcement, strengthening anti-discrimination measures. There are interventions also that public health communities, and I worked at the New York City Health Department for a while, that are not targeted to one group. They're universal, but we know that the geography of where people live, you could say, in New York City, for example, in the Bronx, if you did an intervention there, you would most likely have a benefit for a larger group of people who have been disproportionately impacted, and clearly improving infrastructure and services, especially in countries where you have a lot of informal settlements, what the UN calls slums, building up water so that people can wash their hands during COVID. Those aren't COVID specific or discrimination specific responses, but they address the fact that discrimination has led to an underinvestment in those neighborhoods. So infrastructure is one way. And I know the previous presentation said that a lot happens outside of the healthcare sector. We need health advocates to be saying, yes, we need our patients and our populations to have access to running water, to safe housing, et cetera, et cetera. And finally, a point that I think often gets lost, especially in the international data, is that we need to have some critical sort of what we call transverse enablers and principles of human rights. We need to have data disaggregation. So in a lot of countries in the US, why you hear about racial inequities and COVID outcomes is because we have the data to talk about it. But in a lot of parts of the world, you simply don't. You don't know which ethnic groups, which caste groups, which, whether men or women, young or old, the poor or the wealthy, are being disproportionately impacted because simply our data collection does not allow us to do it. Similarly, something we found out from around the world is that universal birth registration, something we take for granted in Greece and in the US, and legal identity is critical. So a country might say, we recognize these inequities. Everybody who is registered and is poor can get access to, $100. But if you are stateless, if you are so poor that you're no list, you are the ones who are falling through the cracks. So really thinking about the people falling through the cracks, and then dedicating sufficient resources to the community groups who are doing this work. These are key questions that if we had a discussion section, if there is a time for back and forth, I think would be valuable for us to think about. But even if we don't, maybe think back in, how you're dealing with COVID-19, how you're interpreting the data. Are inequities in COVID impact and recovery a central lens through which the pandemic is being discussed in your group of, physicians or public health communities? What are the ways in which the media is portraying COVID-19 disparities? Who or what is being blamed? Is it, migrants and refugees for bringing in disease, or is it the responsibility of the majority for, not providing adequate sanitation, masks to those communities? It's important. The framing is really important. And then, are there good practice examples that we can highlight? For example, Portugal temporarily regularized all migrants and asylum seekers to allow them access to healthcare and social security, which of course was good for the migrants and asylum seekers, but more importantly, good to the entire population. So equity measures, importantly, are important not for the groups, the minority groups or the groups that are being persecuted. They're important for the whole population. And I hope that health equity will be a central lens through which we think about COVID and future pandemics. Thank you so much.
Thank you very much, Dr. Linu, for your interesting and fascinating perspectives. Let's move to our next speaker, who's also joining us virtually, is Dr. Alexis Kalergis, who's joining us from the Catholic Pontifical University in Chile. So we went from North America to South America. Welcome, Dr. Kalergis.
Thank you very much for your for the invitation to be part of this very exciting panel. So I will share my screen. Can you see my slides? Okay, assume you do. So we, thank you. So we've been working during the pandemic on COVID-19 vaccines. We think vaccines are one of the main drivers to contribute to controlling the still ongoing pandemic. So this major viral disease that have been affecting the whole planet clearly picked the human race with no immunity for this virus, and that allowed a very massive dissemination of this virus through the planet. So we realized fairly quickly that vaccines were going to be highly needed and still are needed, and it's important to work on what we call the equal vaccination program for the world. But it was important to first work on developing these vaccines. So we started vaccine development project that was based on the observation that we published early during the pandemic, that the current tuberculosis vaccine, that's called BCG, was able to prevent or reduce the early numbers of COVID-19 cases in countries that have this tuberculosis vaccination program. So during the first weeks of COVID-19 outbreak, countries in green that have a tuberculosis vaccination program based on BCG show, I would say, reduced slopes of cases as compared to countries where there is no such vaccination program. So we analyzed the numbers in terms of cases and deaths, and those countries with BCG programming for vaccination against tuberculosis, they should reduce numbers in general during the first weeks of the outbreak. So this led to several clinical studies that had shown the benefit of BCG as a non-specific way of inducing immunity against this virus. We developed this vaccine that was able to express antigens for SARS-CoV-2 and published this a few months ago. And we are now in the process of testing this vaccine clinically. So our idea is that this hyper inflammatory response that is caused by the infection with the SARS-CoV-2 virus could be prevented by a vaccine that on one hand trains the immune response to control the infection, and also provides antigen-specific immunity based on the recombinant expression of this of antigens from the virus on these BCG strains. Now, in addition to that, we have been in touch with formal collaborations before the pandemic with colleagues in the US, in Israel, China, and France. And I will tell you today about the collaboration we did with colleagues in China. But also we were able to organize a consortium of universities and hospitals here in Chile in order to work together on the development of these vaccines for COVID-19. So we decided to collaborate with this team in China that have developed a vaccine that was based on an inactivated virus, we thought this traditional vaccine approach was going to be safe and also appropriate for the vaccination campaign in our country. They published the discovery in Science, and they did several clinical studies that were reported in clinicaltrials.gov, as well as published in very good journals like Lancet Infectious Diseases. So we established a collaboration agreement, scientific collaboration agreement that that led to the. Are you seeing the slides? Hello? Are you good? Are we good? Okay. Great. So we set up the clinical protocol for the study that was evaluated by the ethics committee of each hospital and institution that was part of the study, and finally approved by the regulatory agency here in Chile, which is has the same qualification than the FDA. And this took place mid-2020, and that led to the initiation of this study that was carried out in several centers in Chile in different cities. And the study had two stages. One focused on health personnel, and the second stage was general population. And the data from this study that we published in 2021 showed that the vaccine had a very high safety profile, as well as the capacity of inducing antibodies against the virus that were able to neutralize the virus both in healthy adults and elderly. In addition, we measured the neutralization levels of these antibodies, showing that we could see significant neutralization after 2 doses with this vaccine, and with seroconversion levels over 90% for all the cohorts that were being studied in this clinical trial. We also measure T cells. T cells are very important for controlling infections, and observed that this vaccine was able to induce significant levels of T cells in both healthy adults and the elderly. And we have published so far about 8 papers on this vaccine, and just showing you here some of them. We also, for each of these publications, we decided to communicate them earlier using a preprint posting on medRxiv. So we've been making all this data available as early as we could. This experience was important to strengthen our capacity to carry out these kind of scientific and clinical trials, and worked in collaboration with other countries such as Brazil, Turkey, and Indonesia. Now that led to the connection between major vaccine producer as is China with us, that we have good science, but we don't have the capacity to make vaccines here. And of course, as part of this collaboration and the data that we obtained, that led to the approval of the emergency use of the vaccine in Chile early in January 2021, that allowed the country to initiate a massive vaccination campaign in early February 21, that set Chile as one of the countries with the most efficient vaccination campaign, that showed pretty early the benefit of vaccination against COVID-19. And you can see here how these different waves of COVID-19 cases, deaths, and ICU requirement were clearly reduced by the effect of the mass vaccination campaign that was possible thanks to the access and the data derived from our study on this inactivated vaccine. Now, population studies show that the effectiveness of the vaccine was pretty high. It started at 67% to prevent symptomatic COVID-19 cases. If you think influenza vaccine is only 39%, this is a pretty good result. And now it went up to about 90% to prevent ICU requirement. So the main conclusions is that this vaccine is safe. We published that 2 doses were required to get significant antibody neutralization capacity. And the most important thing is that the data from our scientific and clinical studies, this data were able to anticipate the population results that we observed with this vaccine in Chile. Now, several questions we had to address after the initiation of the mass vaccination campaign, for example, lasting of immunity, the requirement of boost, whether the vaccine induced immunity is able to neutralize the variants of coronavirus, and of course, very important, the safety, immunogenicity, and efficacy of the vaccine in the pediatric population. So we reported that 6 months after the first dose of the vaccine, people that got 2 doses, the levels of antibodies went down. So then we recommended here the use of a boosting dose for the vaccine. And also we observed that the levels of antibodies or the capacity of antibodies to neutralize the variants was reduced. However, when we provided a boosting, the first boost or the third dose of the vaccine, we observed a significant increase in the number of antibodies and T cells. That was even better when a second booster was given for this vaccine with the same kind of safety, with very few side effects due to this inactivated vaccine. And likewise, the T cells after the first and second boost here in yellow and green remain high in this in the cohort of subjects that are still under study. So that actually led to a real benefit. If you see here on the left in purple, the effectiveness of the vaccine, and this is official data from the Ministry of Health, went up from 60% to 80% after booster dose. Now, the vaccination of the adults in different countries, for example, here on the top is data from Israel, and down below are data from the US, show that countries that advanced on the vaccination of the adult population, they started showing increased numbers of pediatric cases for COVID-19. So the study of vaccines for demonstrating their safety and effectiveness in pediatric population was a requirement. So we set up a large study in Chile to evaluate the safety and immunogenicity of this vaccine in pediatric population. So we found that not only the vaccine was safe in children 3 years and above, but also it was very immunogenic, even more than in adults. So we could see higher levels of antibodies shown here in children vaccinated with this inactivated virus vaccine, but also T cells that not only recognize the spike protein, but also all the antigens from the virus, showing that the immune response triggered by the vaccine in children was safe and also able to recognize several antigens from the virus. That led to the approval of the vaccine in Chile for pediatric population, and several million of children have been vaccinated with safety data that is pretty impressive. We're talking about 0.01% of side effects reported by the regulatory agency in our country, demonstrating that this vaccine is safe and efficacious in the pediatric population. Also, the data from our country, from our studies, was revised by the largest pediatric population in the whole Americas, that's Brazil, and based on our data and the data from the population use of the vaccine, led to the approval of this vaccine in Brazil, a country that did not have at that moment vaccination for children. So we're very proud that this data were not able just to benefit children in Chile, but also in other countries in the region, such as Brazil. So what I show you is the result of basic research with clinical research, with significant involvement of the public and private sector. Of course, the international collaborations are important, but as one of the previous speakers said, it's very important that citizens access to the vaccine, because you might have a very safe and effective vaccine, but if people, citizens don't trust it, then it's like the vaccine wasn't there. So we have spent a lot of time communicating the advancement of research on vaccines, both the good things and also the difficulties that we have confronted, because it's important to gain people's trust in order to promote vaccination. So I'd like to thank the people that work on this, many groups in different universities and hospitals, and I'd like to especially thank my lab. People with masks are in the lab doing experiments and doing some of the assays, and some of them were working at home during the pandemic, helping to analyze data and write our reports and results. So this is how the university looked during the pandemic. Very, sad, very empty, with nobody there. My lab, only my lab, and one few other labs were working. But this year, thanks to vaccination induced immunity, we can see students, faculty, and everybody back in the campuses, and that's also of course, very exciting. So thank you very much for your attention, and I hope you were able to see the slides.
Thank you, Professor. We saw your slides perfectly, so thank you so much for sharing your valuable work. We're behind time, but the organizers have graciously allowed us to have 5 minutes for discussion. So I'll open first to the audience, if the audience has any questions, and for the panelists. And you can bring back the other panelists, please, virtually. Seeing silence, let me ask a provocative question. Given that the epidemiology of the risk for severe COVID-19 and COVID-19 death was so clear from the very outset, based on an age-related gradient with virtually zero risk in children and very high risk in the elderly, why did we do so poorly? And I'm not referring to one single country, but across the world. Why did we do so poorly in failing to protect older people, particularly in nursing homes? And why did we overly restrict children for no reason, like closing playgrounds and schools, etc.?
I'm willing to take the first shot, but I mean, I think in terms of risk communication and science and the evolving nature of it, I think it's important to be humble and recognize that there was a lot that we were learning, right? So the age distribution we found out really quickly, and that should have been our top priority. Now, the question around children and what we do right now, I think we need to continue to be humble. Long COVID is something that a lot of scientists across the world are still studying, trying to understand what the implications are. So I understand that medical doctors who see death in the hospitals, that is the metric that they use, right? Did people die? Are people dying less? Yes, they're dying less. But for those of us who work in public health, oftentimes it is these more quiet, sources of, long COVID. If this is going to mean that a large number of the population is going to have disability long-term, these are things that we can't take lightly, especially when we're talking about something, like air pollution, which impacts all of us. Like if it's a very small number of people, then you don't need to worry as much about these small risks. But if everybody's impacted, then even if 5% of people have long COVID. So my sense is we need to be better communicating what we know, what we don't know, acting on those people who we do know, the elderly, But as I talked about the inequities among, communities of color, we saw much younger people dying and people losing parents, 40-year-olds, 50-year-olds. So it's not that the age distribution was the same for everyone, and being able to communicate that. But I'm sure my colleagues have other answers.
No, I will agree with Dr. Linos. We saw the same thing in Baltimore. From an age distribution, minority races and minority ethnicities, younger. I think the average age of African Americans passing away, the adult population, was in the mid-50s in Baltimore City, which is almost 2 decades younger than their white counterparts. So the age distribution does get skewed depending on the demographics. The nursing home, I can tell you from real world examples, many of them constructed in Baltimore City, especially those that serve lower socioeconomic status individuals, they are not constructed for infectious control purposes, and they did not have the resources. So getting COVID in there spread like wildfire. So that has a lot to do with the infrastructure that was created. We tried to put forth better efforts. I can't tell you they're adequately prepared now, but I don't know if that's a sustainable thing for moving forward for the future. But this is where we need to tap in our public health colleagues like Dr. Linos and others in order to create better infectious control facilities, regardless of the socioeconomic status of the population that they serve. Otherwise, we're going to create another public health crisis in these vulnerable populations moving forward.
As with everything, it's multifactorial. And I'll just add to the list of factors already mentioned by my colleagues, access. So the elderly have interesting and additional challenges to access. And just an example from my experience in Greece, far-reaching villages, islands, which have predominantly an elderly population, they were people that were harder to reach, both from a communication standpoint, from a delivery of care, whether that's vaccination or early presentation to care. And we know early presentation to care is a factor associated with increased survival to COVID-19. So I would add access of the elderly to the system, to the list.
So in Australia, we had a dire situation with elderly population in nursing homes. And what we discovered was that it was not just about health communication, it was also about the nature of the workers who work within the nursing homes and the institutions, because they are often casualised workers, they're often immigrants with poor health literacy, and also much to what you were saying, Dr. Linos, regarding the disaggregated data regarding our immigrant populations and how well they've been catered for in this pandemic. They were casualised workers who didn't have access to any of the work benefits that were available to full-time workers, and so they often worked in multiple different roles and live in multi-generational households. So they were also partly responsible for and our fault also, because we weren't tending to their needs in the way that we needed to.
Thank you so much for that comment. We saw the same thing in the northeast of the U.S., that many of the communities that Professor Kaliatsos and Dr. Linou were speaking about were the same ones working in the nursing homes. So there was kind of a vicious circle between those communities. So I think we have overstayed our welcome for this session, but I thank the panelists, especially those joining us for such a difficult time from the Americas with a lot of time difference. And thanks to the audience for their patience, and enjoy the break. Thank you.
Thank you.
Hi, everybody. I hope you can hear me okay. My name is Dennis Hatzaliadis, and I'm chairing the first session. There are two sessions that are mostly dealing with chronic illness, and then we're going to have a little more focus on mental health. And I'm actually a pulmonologist by trade that recently trained in palliative care, so I'm going to speak to you about this. But I have a lot of esteemed, colleagues that are going to join us from different, places. So I have Dr. Apostolos Hadjikalfas, who is going to talk to us about chronic pain after, my talk, who is the head of the pain unit at Aarau, Switzerland. And we're also going to go down under, and we're going to have Dr. Simonis, who is an associate professor of general practice in Melbourne, Australia, and she is the president of the Women's Physician Association in Australia. And she's going to tell us about the impact of COVID-19 pandemic, especially women healthcare professionals and burnout. And finally, Dr. Stavropoulos is going to join us online from Australia. He's going to talk about internet gaming disorder, which, of course, anything like that is more significant right now in the setting of the pandemic when everybody is at home. As we're running a little bit behind on time, since the two sessions are related, what we decided to do is to keep the questions at the very end of the next session that Dr. Amirali will chair. And we're going to take questions at the very end of the two sessions, for all, speakers. And she's going to introduce very esteemed speakers that she has on her session after me. So, the title of my talk is How Can Palliative Care Support Patients with Chronic Illness? This is my disclosures. This is the objectives. And I'm going to go right to the point. So what's palliative care? So this is the definition of palliative care. And it's basically medical care for people with any serious illness. And in highlight, it focuses on relief of symptoms and stress. The goal is to improve quality of life for both the patient and the family. It is appropriate at any stage of any significant, illness. And it doesn't mean that, you cannot have life prolonging a specific, treatment. And at its base, at its core, it's individualized care. And the goal is to align, the care that the patient receives, which is, appropriate for that person, to align it, with their goals and values. So going to symptom management, what, can palliative care help? So those are all, a list of symptoms that, palliative care can help with. In my specialty, cough and shortness of breath are quite significant, and also anxiety, since if you're short of breath, you're always anxious by definition. It also helps, with as an extra layer of support. It can help with communication. It can help with advanced care planning. And, it goes a little bit beyond the physical distress. So as we know, if you have a chronic illness, many times you can have emotional, spiritual, social distress. And the idea behind it is to try and provide holistic care beyond medications. This is an interesting, study that showed that 80% of people that have a serious illness, they would want to talk about it, end-of-life care with their doctor. But only 25% of their doctors knew that their patients had advanced directives. And only 7% of people report actually having an end-of-life conversation. So this is like a big gap in care, a big area where, quality improvement is important and necessary. A schematic of palliative care, this is, one that has come, mostly as related to transplant. But I would say now it's valid for almost every disease, because we used to, for example, even in cancer, used to think you have stage 4 cancer, you're at the end of life. Nowadays, stage 4 cancer, but before you start, basically immunologic therapy, still can give you, life-prolonging care. So the schematic, of palliative care is basically something that starts any time that you have, any chronic illness that has a burden, which might be eased if you do better with medical treatment, but then it goes up again. And a lot of people confuse with hospice, but hospice is, just for the very end, at a time when you have no other, issues. And the advantage is that in cases like that, in many medical systems, in the US and many of the other systems, you also have bereavement care at the end of this, which is important for the family and the people that are surviving the death. I'm going to give you some examples where symptoms are important, and I'm going to focus on my specialty. I'm a pulmonologist after all, so I'm not going, to the cancer. But COPD, for example, there are 34 million people in the US that have asthma or COPD. That's about 10% of the population. And this is, across the board in the Western world, it's present. And dyspnea is very common in the group. And, about 20 to 50% of patients that are admitted to the hospital have significant dyspnea. So this is one of the defining diagnoses. So this is like a big symptom burden for everybody. In another study of 2,500 European COPD patients, all had, low FEV1. That means their lung function was advanced, but not end stage necessarily. 92% of them experienced dyspnea. And, the 60% had variable symptoms. That means the dyspnea was only at times, maybe when they were anxious or when there was something, going on, but the severity was worse in the morning. So symptom burden is high. Now we say, okay, who cares? It's a symptom, nothing, happens. So I was not, smart enough to realize that early in my career. I was thinking, we need objective measures, Well, dyspnea, how patients, felt, was more important in defining who is going to, do well or not than, lung function, which we consider, an objective measure. So this is an old study from Japan, actually. They had about 227 COPD patients. And what they found out that, grade 4 dyspnea had a much better prediction of who is going to survive compared to an FEV1 of less than 40%. And this is true in other diseases, in cystic fibrosis, which is my, specialty. The same thing was, true. And again, now I'm showing you something in CF. Symptom burden is high. People with chronic illness, 86% of them had, symptoms. They had, more common was pain and dyspnea. And as you can see, if you had to go up the stairs in this adult CF program, the people, that they basically talked to, 90% of them had, this problem. And the other thing, to know, you can see that, patients think about their lifespan. And, of course, if they have more severe disease, they're more likely to want to have an advanced care planning or an end-of-life discussion. But even people that were healthy wanted to have, that discussion to a certain extent from our perspective. And finally, there was not, the correlation was not, perfect with, lung function again. There was a correlation, but it was not perfect. And, another way that this matters, for people that know about cystic fibrosis, recently we had some breakthrough medications that have changed, completely, the disease because they changed CFTR function. The earlier, type of medications that were available, they were very good in stopping exacerbations of the disease, but it created daily dyspnea. Like a lot of patients that had it were feeling, short of breath. So what happened to those patients, even though this medication is good, about, 25% stop the medication in a controlled trial. If you think about it, if this happens in a controlled trial in real life, in my experience, when we prescribe that medication, half the patients stopped it. So controlling symptoms is important in helping patients, get, the medications right. And finally, one more, thing to talk about this is there's a scale in COPD that's called breathlessness catastrophizing. You can see down here some of the things that people say about this. I want breathlessness to go away. I think it's going to get worse. And it's horrible. And, when they did, the scale in 49 patients with CF at the University of Ottawa, what they found out, and they also, got other stuff, what they found out is that breathlessness catastrophizing was positively correlated to depression, anxiety, pain. More women had it, and it was really bad for quality of life. And what they found out is BC was, basically significant predictor of quality of life compared to everything else. In their model, half of the quality of life variation was explained by this. So I hope I made a case that this is an important, aspect. Now you say, okay, why don't you use, inhalers? Why do you do, different things? So this is like, I don't want to, dwell on this for the sake, of time, but patients with COPD, there's multiple trials that show that, for example, low dose opioids can help, dyspnea. And this is, a study from the Netherlands that showed extended release, morphine had a positive effect without creating, a lot of side effects for patients with COPD. So, many times, a lot of my colleagues, even in pulmonary, they're scared. And, I end up seeing them as a palliative care pulmonologist to say, okay, it's okay to use, low dose opioids to help them, improve their symptoms and their day-to-day life after you've maximized every other, disease-specific, therapy. And the only thing, there was more discontinuation because people, on morphine had a lot more constipation and other things. And this is, a COPD scale where, they improved. The improvements were not major, but still important for a day-to-day patient. And this is, again, going back to cystic fibrosis, this is basically a holistic approach from Harvard, medical school, from Mass General, basically. So they did, a whole, series of things that included all those things that you see here on the left side of the slide, acupuncture, acupressure. So every patient chose, what they wanted. And what I found out is doing those things improved, the PHQ-9 and the GAT-7, not a lot, but a little bit, and improved, the MSAS, scale. So, you can see that interventions that focus on those things can have a positive effect on the patients. Second part, of the talk, I'm just going to go to the other part of, palliative care that I think, it's important. And again, I'm mentioning now the Ariadne Labs from Harvard, where they have a program of a way to talk about serious illness. It's the Serious Illness Conversation Program. And their mission is to improve the lives of all people with having meaningful conversations with their clinicians about values and priorities. And, the idea is to have goal concordant care, improve quality of life. If hospice is appropriate, you do it earlier. You lead to less hospitalization and better family and patient coping. And this is, a trial now in oncology, which obviously has a lot more data because they are ahead of us in many of the things. And what they did at Harvard, they did, a cluster randomized trial. They called 19 oncologists and 72%, enrolled. And they looked at 278 patients with advanced cancer, and they were randomized based on their physician, MP, or PA. And about half the patients died, so that's a pretty good sample with a good number of events. And what they found out is that there were more conversations on the group, that had, serious illness conversation training, earlier conversations, and they were easier to find in the EMR. In the US, now we use a lot of electronic medical records. Sometimes it's very difficult to find the conversation. But, if you know how to do it, you do it, a little better. There was a lot of improvements also in the values and the goals, end-of-life planning, and even prognosis. And at the same time, there was no significant increase in the discussion about life-sustaining treatment preferences. So that means that this didn't happen, and at the same time, the patients, didn't get treatment. They got the same treatment. And actually, I didn't put it on my slide, but also there was no earlier death. So the patients that did it didn't die earlier. But they had, basically no change in their anxiety, because sometimes people say, why should we talk about this? Because what's going to happen is the patient is going to become anxious. They had, no changes in depression. That basically proportion of patients with severe anxiety, they were half of the control group. And, they basically also, they had depression. They were half of that of the control group. So actually it was many times relieving. Now, that doesn't mean you go to every patient and you make them, do this, but you get permission, you discuss it. And this is, patient basically quotes. What did you do about this? I changed my will. I had a realistic approach. I make a list of my wishes. And, I told, my family, I'm doing the same stuff, but I'm less anxious about the future. Hope for the best, prepare for the worst. That's the idea behind it. And I'm putting my priorities in order. This is, the outline, and there's different ways to do this, but you can see it's always, basically kind of acknowledging that this is a serious illness, get, permission to discuss. That's the number one, thing. After that, you ask the patient to understand what, they know about this. And then you can never know exactly what's going to happen, but you kind of express, the uncertainty that things, might get worse, soon, or it might be, difficult. And after that, you try with a series of, questions, explore their values. What would be your goals? What are you scared of? What would be the way that you see yourself as whole? Who is your support system? Do they know about all this? And how do you find strength? And at the end, many times that helps you, basically align, let the patient let you know what, their values are, so that your care is aligned to their values. So this is a framework. It's not like magic. It's just a way, to have this structure. And this is, the website for this. I think I'm going to stop, here. And I'm going to get, Dr. Hadzi Kalfas, next, and we're going to do questions at the very end. Thank you.
Hey, I hope everybody can hear me well. Thank you. First of all, I would like to thank you for the invitation. It's both a privilege and I'm deeply humbled to be among colleagues from around the world who are actually one of the very best in their fields. Today, I'm going to talk to you about something that you probably heard on the side of some kind of discussions. We're going to talk about the pandemic that nobody talks about. Over the last 2 years, we actually have talked about one thing, pandemics. And the one thing that everybody's talking about is because of this guy here, COVID-19. But the thing is, what if I told you there's a pandemic out there where the people who are involved, 19% out of them lose their jobs. 18% out of them have chronic depression. 13% out of them actually think about suicide. And 60% out of them go to their doctors 2 to 9 times over the 6 months just to get help. And the thing that's most depressing about it, especially for me as a physician, and I believe for everybody who's involved, is that 77% of those patients believe they get an inadequate treatment. And this is not me talking. This data comes out of a survey done back in 2006. So the data just grew worse and worse and worse. This pandemic has a name, and it's called chronic pain. Pain, if you take the official definition of the ISP, is the unpleasant sensory sensation of imminent or already done tissue damage. And if this pain actually stays for more than 12 weeks, then we start talking about chronic pain. The thing is that when you look into this study that I saw, the data that's coming out, it's actually too shocking to realize that we are not actually talking about that thing, in the way that 1/3 of the European households are actually affected by chronic pain. 46% of these people have actually a continuous pain. 54 have a very significant, maybe not continuous, but very frequent pain. 66% of those patients have a pain in the NRS scale from 5 to 7, 34 over 8, and 60% almost have this pain syndrome for more than 15 years. Across the Atlantic, things are not better. It's almost the same, if not worse. So why is it happening? What are we talking about? Well, most of us who are actually not treating, or most of our colleagues who are not treating pain as the main symptom, just see the tip of the iceberg. But the truth is, there is much more behind it. And this is what we have to realize before we even start about considering a treatment about those patients. There is a vicious circle, who is being connected to chronic pain. Chronic pain leads to the diminishing or reduction of movement. Reduction of movement actually leads to muscles being deteriorated or not working well. And as you can see from this circle, it all circles back to more chronic pain, and then more chronic pain and more chronic pain. And the one thing that we have to understand before we even start about treating those patients is chronic pain is not just a somatic thing. Out of the whole problem, out of the whole equation, only 30 to 40% is actually the somatic part of the pain. The chronic pain syndrome in the patients that actually have this syndrome is, let's say, a sum of 3 different factors: social factors, psychological factors, and then the somatic part. So if we want to be actually successful in what we're doing, we have to address all 3 issues. And I know what most of my colleagues think, especially the surgeons. I don't have any chronic pain patients. My patients are excellent, and I never ever see them in my practice after my ORs. Well, the numbers are not in your favor. They're not in my favor. I'm a neurosurgeon myself, so I know what I'm talking about. And just because I don't expect you to take my word for it, I put the studies, which are more than 20 years, some of them there, just to prove to you that the same source that we use to get our literature, which is PubMed, also has this data. And the one thing that you have to understand is that at the very end of things, there is no surgery that doesn't lead to chronic pain. There is no medical procedure that at some percentage won't lead to chronic pain. And this is what we have to understand in order to go forward with the treatment. So what do? Well, in the immortal words of Will McAvoy, the first step into solving a problem is recognizing there is one. The normal algorithm when we're treating patients is, of course, physiotherapy. We start with physiotherapy. Then we start getting patients into pills until the patient has 3 meals a day with just pills. If that doesn't work, we start injecting stuff to the patients. The surgeons start playing surgery. until we have a situation like that where we don't actually really want to talk about surgery and we try to do other stuff. The thing is that nowadays we have to talk about the multiverse of chronic pain management and treatments, which means that if we want to treat successfully our patients, there has to be more than one specialty going on, which means that it's not longer in one man's field to play. We have to work all specialties together: orthopedics, anesthesiologists, physiotherapists, psychologists. Everyone, every specialty has to contribute or can contribute in some way to the treatment of these patients. And this is an example how. Each of us, according to what training we had, we actually have something to contribute, some small part of the therapy, but it has to be in a way of algorithm so that we can treat successfully and manage these patients until the end of their lives. We're talking about patients that actually come to us nowadays at around the age of 50, 55. So if they have a median expectancy of life for more than 75, we're talking about managing their symptoms for more than 20 years. So we can't just give them opioids so that they will feel good, and then in 2 years' time or in 12 months' time, still have them in our practice coming every single day saying it doesn't work anymore or going up high with the doses. So we have to have an algorithm combining those things so that we can actually help the patient and manage them for the next, let's say, if we're lucky, 20, 25 years of their life. What does it mean? Well, the goal first is to manage the pain, but the end goal should be to enhance quality of life. That's why we treat chronic pain patients, to give them quality of life, to let them walk more, let them participate in more social presences, let them actually have what it should look like a normal life. Why? Because we want to turn this circle to this circle, which means we want to show the patients that there is a world out there where they will still have some kind of pain, but that pain won't block them from living their lives. That should be our goal. This is what we have to focus. Thank you very much.
Thank you, Dr. Kalfa. I think next we're going to have Dr. Stavropoulos, who is going to join us from Australia, and he's going to talk about internet gaming disorder. Vasily, you're okay? You're live? You need to unmute your mic.
Thank you so much for the privilege to present my work from overseas and attending this conference. So the title of this presentation is Internet Gaming Disorder, Risk and Protective Factors, which is mostly what I do research-wise. Chronic diseases are defined broadly as conditions that may last 1 year or more, require ongoing attention and treatment, limit activities of daily living, lead to death or disability, and refer to either physical health conditions or mental health conditions, such as addictions, where gaming disordered gaming, is included. And aside from belonging to the broader family of the Greek diaspora, it is this family of chronic conditions that brings together from the different sides of the world Dr. Hadjiliadis, Dr. Hadjikalfas, Dr. Simonis, and myself. My presentation aims to briefly describe disordered gaming behaviors, explain disordered gaming-related in-game mechanics, and illustrate implications and further research recommendations. Aim 1, describe disordered gaming behaviors. Internet gaming disorder is mostly considered an addiction. Thus, as every other addictive behavior, satisfies 6 criteria. Salience, which means a specific frequency of the behavior within a specific period of time, once per day. Mood modification, one does it to moderate how they feel. Tolerance, gradually higher doses of gaming is required for one to achieve the same outcome. Withdrawal symptoms such as irritability and frustration when one is not gaming. Conflicts and functional impairment when excessive gaming is established. Educational, professional, and family roles and activities are neglected with others in the surrounding of the person complaining, and relapse, despite aiming to reduce or even abstain from gaming, the person fails to achieve that. The sufferer surrounding experiences gaming disorder via 3 interrelated behaviors, the core ones. One is lack of or dysfunction of substantiate relationships. One might be surrounded by others, but they don't actually communicate with them. Lack of boundaries or sufficient control. This is manifested by the way they manage their space. It could be messy, their time. They might be sleeping in the day, awake in the night, and even the way they're managing their money by over-investing in the world of the game. Last, lack of responsibility, accountability, or manipulation. As with other addictions, we have a victimization narrative. It's a blaming of others or conditions around the person, usually. Now, the individual themselves experiences their disordered gaming condition as combining 3 things. One is a strong need for immediate gratification. I need to do that. I need to gain to feel the relief, satisfaction. The second is compulsion. Every time that a distress triggering condition causes them arousal, they compulsively need to gain. And finally, impulse control deficits. Even the times that they would like to reduce gaming, they fail to do so. The current diagnostic criteria from the side of the APA, the American Psychiatric Association, included as a provisional diagnosis in the context of DSM-5, requiring further study, while in the context of ICD-11, the World Health Organization, it's a formal diagnosis since 2019. And the above behaviors are reflected in the criteria. Second aim, which in my opinion is the most important, and it's the core of my research work, is to briefly explain disordered gaming-related in-game mechanics. And as many of you are parents or might be gamers, please pay attention. To paraphrase, what is actually addictive about games? The answer is the same game qualities that make them engaging or absorbing. These involve one's experience of the virtual world, the game world, their virtual self, and how these two interact by the experience of one's online activity. Presence, online self, flow. What is telepresence? Telepresence or presence is a psychological state in which an individual feels like being in the digital world instead of reality. It occurs in the human mind and not in a specific technology. So actually the user uses technological means to experience the game world. And when they forget that they are using these means, they actually feel there. They actually experience presence. It's like looking into a landscape through a window frame and forgetting the frame. You feel as if you're there. Presence has been shown to increase within augmented or mixed realities. These refer to predominantly virtual spaces where physical elements or people are integrated into and can interact with the virtual world in real time and possibly with real repercussions. These are mostly what we call massively multiplayer online role-playing games. So it's virtual worlds when a gamer, an individual, assumes the role of a character, and the character develops in a way parallel to the way we develop in real life. They form friendships, they have professions, they have income. An example of augmentation could be currency exchange. So each of these virtual worlds has a currency, and these currencies have daily exchange rates that fluctuate the same way that real life currencies do. Now, absorbance by the digital activity, what we call online flow. For one to be deeply involved in gaming, the continuous maintenance of a dynamic balance between their gaming skills and challenges is required. So if with yellow, we have the gamer skills, and with green, the game challenges, and the game challenges are at that level, high, the gamer skills need to be slightly lower for the person to feel challenged and engaged. If they are significantly lower, then they feel distressed and they disengage. If their skills are significantly higher, then they feel boredom and they also disengage. However, the more one is gaming, the more they are improving, and thus to maintain this sense of challenge and engagement, gaming demands need to match this rate of increase. So gamer skills increase, Game demands need to increase, and that goes on. And it's what we call in the world of the games level up process. Now, absorbance by the experience of one's self online, as this is expressed by their customized game character, what is most commonly known as avatar. Paraphrasing Freud, avatar is the royal way to the unconscious, and our work has shown that an unhappy user can relate with a happy avatar through 4 channels. The first is what we call identification. I am who that persona is. The second is immersion. The needs of that persona in the world of the game are experienced as my real life needs and may be often prioritized to my need to sleep, eat, or socialize in reality. What is called as immersion. Repression, which is this persona in the world of the game can behave in ways that I would not allow myself to behave in real life, maybe more promiscuous, more violent, more inappropriate in many ways. And finally, idealization, that persona is or can become to an extent who I would like to be, my ideal self. And aside of the character and how the user is affecting the character, the persona, the avatar has also been shown to affect the user with something that actually has a Greek name. It has been named Proteus effect, not by me, by other researchers. Proteus used to be the Greek god of transformations. So avatar has this transformative capacity for some of the gamers, making them behave like their virtual character in their real lives after a point. And that can be both positive and negative, depending on the behavior. Important notes, game-embedded algorithms, a word that Dr. Hadjikalfas used before, supervised or unsupervised, such as random forests or convolutional neural networks, use the granularity related to big gaming data to progressively increase prediction accuracy related to an individual's gaming pattern. Basically, when one games, their behavioral patterns, their usage is documented. There is big data there, and then these are analyzed to help tailor one's gaming experience to their distinct profile, so that their engagement also increases. Therefore, algorithms function as exacerbators or moderators of one's experience of presence, online flow, and virtual self. Third aim, I'm going to be very brief, illustrate implications and further research in the light of the emerging literature. I will aim to highlight only the positive part and not the negative part. Can we turn game mechanics from a part of the problem to a part of the solution? Can gaming disorder research indirectly provide solutions for other health or mental health problems? Yes. Firstly, the same engaging game mechanics can be used to produce what we call serious games or games for health. Example is Depression Quest. It's a behavioral activation game introduced here in Australia years ago, which helps sufferers of depression. I could talk about various of these games. Secondly, the user-avatar bond has been shown, and this is, in my opinion, very, very important, to carry information of diagnostic value about who and how the users are in their real lives, operating as we say, as a cyber phenotype. The same way, what does that mean? One's online behavior can provide diagnostically valuable information as their real life behavior. The same way that if I have reduced appetite or sleep disturbances in my real life, these could be indications of depression. The same way, my gaming patterns or my online usage patterns can be the footprint, the digital footprint of who I am in my real life and what's happening. And this is exactly what my research work is about, and my team's research work is about, decoding the bond between the avatar and the user. And during this journey, this research journey, we concurrently collect psychometric data, actigraphy data, Fitbits, and also mobile monitoring usage data, which we analyze with machine learning profiling algorithms. I'm not sure how many of you are familiar with that. It has become my passion recently. And during this journey, we met with other Greeks of the diaspora, not medical or mental health practitioners, but information technology researchers, such as Professor Vasilis Kostakos from the University of Melbourne, who has introduced the freely accessible Aware Light app, amazing tool for research, and Professor Giannakakis from the University of Malta, who does amazing work, literally amazing, it's jaw-dropping what he does, on emotional computing. You need to read some of his work. And I felt the need to bring their faces, at least here with us today, Vasily and yours. I would like to thank you. I hope I didn't consume your time. I'm leading the Cyberpsychology and Online Behavior Research Group in Victoria University, and I have received the Australian Research Council DECRA Fellowship in 2021. I migrated from Greece in 2012 at the peak of the crisis. This is why my thick Greek accent remains. Thank you so much. Thank you.
Thank you, Vasily. If anybody has any questions specifically for Dr. Stavropoulos, please ask them now, because I heard that you are, it's late in Australia, so you're not able to stay until the end of both, sessions. Am I correct? So if anybody has any burning questions, please ask them now for Dr. Stavropoulos. So the question from Dr. Lemberis is, how can we get your slides?
You can email me, and I'm happy to share them. I've also provided them to the organizing committee.
I have, a very simple, is there any advice in the middle of the pandemic where people, were always at home and they probably were more likely to be addicted on this? What advice do you have, especially for the young people? For many of us, we have, young kids and we see them, being online more. Do you have any, how to help, prevent things from happening?
I think I like very much the word prevention. The answer is awareness. We need to know the digital products we consume, and we need to know if these products involve algorithms. We need to know the level of presence and flow that they involve, and actually we need to have policies. I think the public, the consumers like me, my family, we are not always aware of the digital applications or products that we are consuming. And I think this is the first step to prevention. And the second step is us as health and mental health practitioners, those who have a knowledge in the field, push towards the introduction of policies. Because I'm going to use Australia as an example. We have a very strong gaming industry, 30% of which is based in Victoria. Gaming industry has been interfering with has been interfering with politics, if you ask me. In 2016, they pushed a discussion to the federal parliament about gaming and how the industry needs to be protected. And at the same time, we don't have a public center like the ones we have in Greece, in the psychiatric hospital of Attica or Kethea, to treat sufferers. And I think we have a big issue, because the Better Access to Mental Health initiative is not sufficient. My apologies if I'm consuming your time.
One last question. First of all, congratulations on a wonderful talk. Can you hear me now? Yes, it's better. So my question is, have you seen some kind of age barrier after which trying to treat people with this kind of addiction, the percentage of success actually drops down? Or is there a peak where you can say, as long as the patient is in this group of age, can gain maximally to some kind of treatment concerning this kind of addiction? Or is it something that it's when it comes to AIDS is independent?
I will start with the positive aspect. Studies, one of ours actually, have shown that when it comes to excessive gaming for adolescents, there is a pattern of increase between 12 to 16, and then for the majority of adolescents, even those who present to have been gaming excessively, that drops. So it seems to be a developmental trajectory when it comes to adolescents up to the age of 16. Of course, data constantly changes, with only some continuing. For those who continue, though, the data until now do not present optimistically. So the percentage of success, even in organized treatment centers, is 40%, the maximum, as with other addictions. And what we also know with gaming disorder and other technological addictions is that they function with high comorbidity, with other mental health problems and issues, and they have high relapse, and they could be the initial step for other forms of addiction, such as alcohol, gambling. We have gaming companies introducing loot boxes, actually promoting gambling patterns into the gamers, into the community of gamers. So we have what we call addiction hopping behaviors. One might disengage from a game and substitutes that addiction pattern with another addiction. So there is an optimistic part of research, and there is also a pessimistic part of research. And I think the most problematic thing is that governments, policies, and even us, researchers in the field, are behind companies, producers, when it comes to algorithms, mechanics, and things like that. We are behind. And I'm going to be a little bit more frank because I'm speaking to a Greek audience. I would like to think, and it's allowed to be politically incorrect, the way I remember my life in Athens. The problem is that the industry funds researchers. We have conflict of interest in the field. So you will see that there are studies which show that games actually are not addictive. They don't cause behavioral problems, but there is no disclosure in terms of where these researchers find their funding. And that's a quite significant issue because it's a very, very powerful industry. That's in my opinion, that's my view of it being 8 years active researcher in the field. Thank you.
Thank you.
Thank you so much, Vasilis. So we're going to go to our last, talk with Dr. Simones, who's going to talk to us about women distress during the COVID-19 pandemic. And she's also from Australia, but she's in person. We introduced her before her title. Thank you.
Kalimera σας, and good morning, and thank you very much for inviting me. I'm very honoured to be here, the birthplace of my mother and husband, and I want to say thank you to the Hellenic Ministry of Health and to the University of Aristotle here in Thessaloniki, and to the organising committee of the Hellenic International Conference of the Diaspora. This is a wonderful opportunity. I'm a GP, a general practitioner. We form a very important part of the health sector in Australia. Primary care is the gateway to the health system, and I undertake research through the Department of General Practice at the University of Melbourne. And alongside two other esteemed colleagues, one Professor Antonella Vezzani from Italy and the other Professor Magda Carneiro Sampaio from Brazil, during the COVID pandemic, we connected through Zoom, as we do, and we undertook a research project which I was very keen to undertake and thought it would be nice to invite some friends from overseas to participate. And this is the outcome of that. So the purpose of this was during the COVID pandemic, there was, of course, a crisis that was faced by the entire community. But, we as women doctors were working throughout this period. And I also am heavily involved in addressing gender disparity in our health profession and also gender inequity in the delivery of healthcare services and in underprivileged and underrepresented communities. So it became inevitable that during the pandemic that it would be worthwhile looking at some sex disaggregated research and to undertake this survey, which is what the baseline behind this was. So the survey was sent out internationally. And the key areas that were investigated, of course, the usual demographics, whether or not women worked during the COVID-19 period. So it only looked at women who were working during this period, how it affected their income. The questions asked around PPE, personal protective equipment supplies and fit testing specifically, workplace safety, support provision during the work period, information access during the pandemic, vaccinations, their accessibility, and personal experiences of COVID, such as mental health and mental well-being. And then there were 2 open-ended questions, which received some very interesting responses with a request for recommendations for how we can better do things. And of course, as the various COVID waves spanned across the globe, different countries were experiencing different phases of the wave. Australia lagged behind, where some countries were in phase 3 and some even phase 4. We were sort of exiting phase 1, entering phase 2. It was completed by around 1,447 women, 75% complete completed the survey, and the largest proportion of survey respondents were from Sweden, Italy and Australia, which was very interesting. So I think it sort of gives us a good distribution. 56% had worked for more than 20 years, so they're a very experienced cohort of practitioners, and 86% worked in urban locations with very few representing remote and rural. And this was general across the whole board when we looked at, broke down all the statistics. Of the distribution of professional subgroups, the majority worked in primary care or general practice, but it represented more heavily in the Swedish, Australian and Italian cohorts. And the rest were sort of physicians around the 17% mark, somewhere in research academia, obstetrician, gynecologist, and less and less and less towards the surgeons. So we had more in primary care represented. Around 40% had worked full-time, face-to-face throughout the entire pandemic, and around 54% described not having sufficient PPE supplies throughout the entire period. And that's maintained now. So in the initial stages, though, the question there asked around the staging of the PPE access. So the first 6 weeks, the first 3 months, and now. And of course, it gradually sort of improved, but it's leveled out at around the 53%. So 38% or 39% had treated patients with COVID, which is very interesting given the lack of access to PPE. And around 65% had not been tested and still are not. And that is especially high in primary care. So this is just to give you a distribution of female doctors around the world and how important we are in terms of the health workforce. In most of the developed countries, we constitute somewhere between 40 to 50% of the medical population. In some countries, as you can see in Eastern Europe, even as high as 75%. And it's only in places such as, Korea, Japan, where they're really around the 20%, and that hasn't really increased over the years. So we constitute a pretty significant proportion of the population. So some of our specific needs, I think, probably will be of interest here. This is the distribution of the countries. Nigeria came after Australia, Netherlands, Taiwan, United Kingdom. Interestingly, a lot of the English-speaking countries did not respond that much to the survey. We had more responses from Japan and Taiwan and Brazil. So in terms of age group, this is also interesting because the age group of the respondents was really quite high. The vast majority were over the age of 35. And in fact, a very large proportion, you'll see there in the orange, were in the 55 to 64 age group. And there were quite a few in the 65 plus age group. And then there were many who actually came, well, a significant proportion who came back out of retirement to meet the needs of their communities. And this is really important because much like the general population, doctors are ageing. So we need to support doctors better. If we're not supporting doctors, our health system fails. And pushing people to their limits through their career and also at late career has implications regarding burnout. Not just health issues, much like the general population, which was also facing incredible risk. So the older the population that was exposed to COVID, it was the older population that had higher risks. And as you grow older and as doctors grow older, their incidence of chronic disease is also higher. So they also face greater risks than the general population. So this just looked at how many years the doctors had been working in practice. and the professional category, just as outlines. And this is just a breakdown of the actual groupings of general practice versus other generalists and specialists. And you'll see Greece is at the extreme end of that particular slide. So primary care in Greece does not feature very much. You'll see that Australia, Belgium, Finland, Portugal, Canada, and China and Chile, we are very high. So general practice and primary care features very highly in those health systems. So perhaps part of what we're seeing here is also something to consider in terms of the primary care status and also distribution and availability to the community. So have you been working? Yes, as stated, of course, a good proportion have been working full-time and face-to-face. And the interesting results here with this question in particular, question 22, around their responses, looked at responses around information managing patients, and around 50% said that there was a lack of information around how to manage patients. Again, close to 40-odd% felt that they felt pressured to work longer hours. A very large proportion, you'll see here, all close to 80% felt concern regarding exposing themselves to their disease or exposing their family to the disease through their work. This posed an incredible conflict of duty to job, duty to family. They also felt exposed to the risk of contracting COVID naturally without fit testing and with the inaccessibility to PPE. And that was in the order of around 80%. And, well, unsurprisingly, it was, interestingly, some actually felt very well supported in their workplace, which sort of sounds rather contradictory in terms of how their response rate to PPE access and pressure to work longer hours. Mental health deteriorated in a good 50%, and anxiety levels increased in around 50+%. And these were some of the key words that came up when we looked at the word cloud, just in terms of what issues were repeated over and over again. PPE, patients work, COVID lack, family, masks. So the issues raised from the open-ended questions were about the work-life balance, homeschooling, career role, carer role, and pivoting to new roles. They were raised repeatedly. Gender inequity, both at work and at home, were also key issues raised. The PPE and work safety, which they felt were markedly reduced, access to PPE reduced workplace safety, and that their mental health declined. And it was impacted mainly by the conflict they faced in their carer role and the expectations of work. Pregnancy and working during COVID-19. Now, this is something we didn't really consider as much as we did and had to during this period. You know, there was such poor information. I mean, how safe were the vaccines? Whether or not you could still work in ICU, whether or not you could work as a respiratory physician, and there were no adjustments made according to pregnancy status in most of the workplaces. Vaccination, when it became available, information around it, access to it, and also safety during pregnancy. So there were very mixed messages around that. And then there were issues around communication, dissemination of information, and there were issues around leadership and who was in leadership and who were making the decisions and the communications. In most countries, women felt that they were doing the work, both at home and in the workplace, and they felt that it was men who were doing the leading. So the conclusions were that the majority of medical women's ability to work was severely impacted, more so than normal, that the existing gender inequity issues in the workplace were amplified, and that the carer role at home and gender inequity in the workplace. So it was basically also an attitude in the workplace. Well, you know, you can go home and look after your kids and these men will just take on your role. And in fact, or if you do, you work those hours, and it was inflexible around how they could manage their home work duties. Carer role stereotypes of women doctors impacted their career more so during COVID-19, and there was a lack of PPE, a continuous lack of PPE. Fit testing is still not widespread, it's not being mandated, and it's not being supported in most environments. And medical women have been working in leadership roles at the front line whilst managing risk of transmission to self, loved ones and dependents, but they've not been given a lot of recognition for their leadership, or they've been mobilised in the communities, reaching out to communities and doing much like the type of work that Dr. Linos was talking about earlier. And that the juggle was costing. So these are some of the free statements that were made. And as you see, they wrote paragraphs, so there's a lot of information in this. So I'll just read this one out. COVID-19 certainly highlighted gender-based behaviours in society. Often it is men who have prioritised continuing to work whilst women have made sacrifices to look after children. We've not had access to our usual childcare, and as we've not wanted to ask our parents to look after the children to protect their health. This has meant that particularly when the schools were closed, that we had to do more childcare ourselves. It was me who sacrificed work hours and extra shifts, teaching extra so that my male partner, who is a surgeon, could continue his full-time work. There's still a perception that it would not be right for him to drop down his part-time hours, and instead that I pick up the slack. Because of all this, I had no time to pursue my PhD application that I had intended to make this year, and I wanted to pursue an academic career alongside my GP career. Yep. So, and everything was put on hold. And this included, you know, being demoted from the position, having 3 men placed into my role. Very repetitious, but very similar. And given the number of respondents from around the planet, and some wrote very similar things in English that, you know, showed that it was their second or third language, and uttered very similar statements. So, you know, women being told, go home and look after your children. My medical husband was never told this, yet he was the one who was going to care for the kids so that I could be available to work in the front line if it required. So work during COVID, work-life balance diminished, work changed. Women described feeling unsupported by the workplace, and these are sort of a breakdown. I'm going to race through these. It's all available. COVID was affected the ability to work by changing due to vulnerability, some due to illness, their own chronic illness. Some were forced only to do telehealth, and some felt that the risk during pregnancy was inappropriate. And some described working in the front line more than men. Some felt that they were not involved in decision-making, and that they published less during the pandemic, and that the carer role of women doctors was not taken into account by the health system, and that breastfeeding doctors were unable to express milk. And then there were other issues around menstruation, wearing PPE, like, you know, logistical problems. You know, how do you sort of manage all of this when you're working 12-hour shifts in the front line? And the mental health burden. So compassion burnout, working long hours, feeling unsupported, ethical dilemmas, dealing with patients selecting who to go onto ventilators, and the lack of psychosocial support. And childcare, you know, and this is not just a gender issue. This is a humanity issue. This is the whole, because when we say that it's the role of women to look after their children and professional women, that's basically saying we're excluding men from their role. And I think that from the many men that I have met, many have felt that they miss out on raising their children. And really, childcare is one of those things that benefits everybody and all of society. So I think we need to start changing that conversation around childcare, and that workplaces need to address this, to be fair to both the women and the men and their families. So again, carer role, I won't go into more detail, it's repetitious. Remuneration altered significantly, and of course the issues around PPE, COVID and pregnancy. Vaccine availability, it was scattered, it was staggered. And in primary care, I can say we were the last, and yet we were the gateway to the health system in our country and in a lot of countries. So we were the last. We were sort of like class 2B for delivery of vaccines. And yet we were seeing people in the community and tending to people in the community. And then the inconsistent messaging affecting our level of trust, and the leadership issues from top down, not including women, not including primary care, you know, fairer representation of the people that we're trying to serve. So we need leadership. When we talk about leadership, we talk gender, but we also need to talk about really having our marginalised communities represented in those leadership decisions too. So these are the equity advocacy issues that have been raised through this around undertaking gender equity review in the workplace and work flexibility, remuneration issues. In-house mental health support is something that is recurringly being raised in lots of different fora. Childcare, providing this for our healthcare workers. Leadership and fair representation and inclusion of women from the outset. Safety protocols to incorporate a gender lens, and workspace design, ventilation, childcare, breastfeeding. Thank you very much for your time. I'm very welcome to questions and invite you all to link in with me too. So thank you very much.
Thank you, Dr. Simones. You can come up, here, and we will go straight through, to the next session and have questions all together at the end for everybody. And next, Professor Amiralis is going to take over for her session on mental health. And she's going to introduce everybody else, from the speakers. She's a professor at the Université de Montréal and McGill University of Child Psychiatry.
Thank you, everybody, for being here and missing on the lunch, I think, and for actually staying and being so patient with us since we continue nonstop since this morning. So this is the mental health session, and I have the great pleasure to have with me some wonderful colleagues from very famous that I'm looking forward to listening to, that have been on the field for many years that I'm going to introduce right away. So I have Professor Paxinos. If you could please get up, thank you. Professor Paxinos is a world-renowned psychologist and researcher. And let me just go back for a second. And researcher who is one of the most cited neuropsychologists today, and we're looking very much forward to his presentation. Dr. Limberis, who is a legend in the American Psychiatric Association, and as far as I remember, at least the most important person in the Hellenic American Psychiatric Association for a large number of years, and I wish you the best of health. So we continue to enjoy with you, Dr. Limberis. And finally, Dr. Vasilis Stavrakakis, Latusakis, my excuses. I'm really so sorry. The 2 coffees I had since this morning, I guess, were not enough. So Dr. Latusakis, who is a colleague previously from Cornell and who leads a unit, a program on geriatric psychiatry. So we represent, I think, all of us together, the length and depth of psychiatry, from the psychoanalytic spectrum to the research, neurophysiology and genetics, from the child psychiatry that I'm going to talk shortly, to geriatric psychiatry. So I'm very glad to be with you today here. And I'm in Montreal, Quebec, and I wear many, many hats, but with the Royal College and with the Canadian Academy of Child and Adolescent Psychiatry, with the Quebec Association of Psychiatrists and Hellenic Medical Association of Quebec. So I will talk to you very briefly on ADHD and comorbidities. And here are my disclosures. There is nothing, no conflict of interest for this presentation. The learning objectives is to talk very briefly about the prevalence of the most common comorbidities with ADHD. And I think, having listened to our colleague from Australia and the gaming disorder, it relates very much to issues that have to do with ADHD. We will try to identify some of the overlap of symptoms between ADHD and comorbid conditions. And finally, we'll talk about briefly treatment recommendations. So what is extremely important to understand is that ADHD often doesn't exist in isolation, quite the opposite. So the statistics are that 50 to 90% of children and about 85% of adults with ADHD have at least one comorbid condition. And it is very important to evaluate and screen, because often when we see what we call treatment resistance or difficulties in treating somebody, we have to consider what else there might be there. And the fastest we treat in mental health, as we know, the better the outcome. And that always helps, especially in the developmental trajectory when we talk about children and adolescents. So from the National Comorbidity Survey, who dates to 2006 in the States, and this is data for adults, we see that the rates of ADHD among patients with other comorbid disorders are quite high. So among people with major depression, close to 10% of ADHD, in bipolar disorder, almost more than 20%, 21.2% with ADHD. In what we used to call dysthymia, now we call persistent depressive disorder, more than 22%, and with any anxiety disorder, about 10% of ADHD. So it is important that we screen and we ask equally in primary care as well as in psychiatry for ADHD with all those disorders. Now, when we look at comorbid conditions, they can complicate ADHD evaluation and treatment. And in fact, this comes from the CADA, which is the Canadian ADHD Resource Alliance. And the common comorbidities are many. There are special presentations that can sometimes confuse or make it difficult to diagnose and identify the problem of ADHD. And there are medical conditions with overlapping symptoms that we have to differentiate from the beginning. And those are medical conditions such as, obviously, vision, hearing impairments, thyroid dysfunction, hypoglycemia, severe anemia, lead poisoning, which unfortunately in Canada we see sometimes in marginalized communities and in our Aboriginal communities. Sleep disorders, fetal alcohol, which spectrum disorder, neurofibromatosis, etc. I would like to underline sleep disorders because lack of sleep, which some of us with jet lag may suffer right now, actually can mimic ADHD. And in fact, sleep disorder often is a comorbid condition, but sometimes it gets worsened by ADHD. And like Barkley, who is one significant researcher on the ADHD field, says, sleep deprivation is like having a hole on your prefrontal lobe. So right now we have to, consider all of us our state and actually take care of sleep and address it very seriously in any, difficulty that we have with our patients. Now, in terms of some special presentations, the diagnosis of ADHD becomes more challenging the more intelligent somebody is. And when we talk about people with intellectual giftedness, it is quite difficult to identify if somebody reacts a certain way because they're just bored and they are above and beyond the speed or what is expected, especially in the school system. But at the same time, the harder it becomes to compensate with age because of what is expected. And depending on the type of ADHD, we have to keep it always in mind, because being gifted or having high intelligence does not mean that somebody does not have ADHD. Obviously, with psychological trauma and in terms of memory and all the games that psychological trauma can play with our memory and with our capacity to react to situations in terms of our impulsivity, etc. It is another presentation that is challenging. DCD, epilepsy, brain injury, anything that affects the brain affects also cognitive function and attention. So in terms of common comorbidities, I will come back to that a little later if I have the time, but just to tell you that some of those, the true comorbidities, are the ones that coexist and the rate doesn't quite change over time or with other factors, but there are also certain comorbidities that actually are being affected by the ADHD, and over time they get worse. So there are ways, all this knowledge and understanding helps us see how do we address two things together and what do we do first, or how do we avoid the trajectories of mental health for the rest of the life of somebody, especially when we start early. In terms of conduct disorder often coexists with ADHD. It shares the impulsivity. I will talk about the sharing factors a little later. It is quite interesting to talk about borderline personality disorder because today very often we confuse, especially in adulthood, we confuse some of the symptoms, and it becomes complicated, and often medication is used to treat when it should not be the case. Substance use disorder and addiction unfortunately shares impulsivity and shares the need for quick gratification with ADHD, and it becomes an issue, especially if ADHD is not treated. Anxiety disorders may worsen with ADHD, but they can be comorbid as well. Major depression, as we said, unfortunately quite frequently. Bipolar disorder, there's a lot of literature as well as for disruptive mood dysregulation disorder that looks at these factors. In fact, DMDD became a disorder in DSM-5 from the literature on the Smoky Mountain study that came out where we're trying to see if ADHD was a precursor of bipolar disorder or not, or the two were independently coexistent. Obsessive compulsive disorder can be comorbid with ADHD. At the same time, often we can see people with ADHD having certain sort of obsessive behaviors, developing lists as a way of compensating for their ADHD. We should not confuse the two. Tourette syndrome and tic disorder is another neurodevelopmental disorder that coexists with ADHD. Quite often we have the triad of OCD, ADHD, and Tourette. And sometimes autism spectrum disorder can be added to that. Eating disorders, depending on the pattern, they can be comorbid with ADHD, as well as learning disorders who are truly comorbid because they either are there from the beginning of life as part of neurodevelopment or they are not. So I will just describe, I will go a little more at length on some disorders that are more often comorbid. So mood disorders, with mood disorders, adult ADHD can go often unrecognized and untreated. In fact, my personal interest with ADHD started after I was treating for many years adolescent depression. And I found myself having to treat ADHD because once you treat depression and you do a lot of cognitive behavioral therapies, I was doing at the time and I still do, you reach the sort of basic beliefs and the automatic thoughts that make the patient feel that they are stupid, they're not good enough, and they're actually self-esteem is affected severely because they feel that they can perform at times very well, but at times in the same material, not well at all. So they lose, these kids and adolescents, they would lose their motivation to work and they would feel more and more depressed. Now, we know that there are genetic factors that unfortunately bring the two disorders together, and they coexist in families, and you can have ADHD with depression. But it is quite important to make sure that we screen for both, especially when somebody presents with a history that is compatible. At this point, I would like to mention that it is important that we use diagnostic instruments, both self-rated scales as well as observer-rated scales that can help us identify, and in a way they can objectify our findings and our observations in clinical exam, and at the same time they become extremely useful if we introduce any type of intervention, either psychotherapeutic or psychosocial or any pharmacological intervention. So we have to also make sure that when we diagnose ADHD, there are no mood symptoms present. We do that during the time of a remission of the mood disorder in a period of sustained euthymia. And we have to make sure that at the same time we ask, we make sure that the history of ADHD has started early on in life, because ADHD does not start at the age of 20 or 25 or 30, even though there is some data today by BUTLR that talks about first appearance of ADHD without any concussion of head trauma in adult life. So you see here some of the slides on comorbidity and the comorbidity of adult ADHD and other disorders, and you see that it is bidirectional. So we have, I just spoke earlier how when we see ADHD in major depression or in other psychiatric disorders, and here you see that when you have how much ADHD we see in actually mood disorder. So in major depressive disorder, it is more than twice the proportion of ADHD. In bipolar disorder, much higher than that. In any mood disorder, more than 3 times over. And here you see the same thing in generalized anxiety disorder, PTSD, panic disorder, specific phobia, social phobia, or any anxiety disorder, much more prevalent in presence of ADHD. So you have, as I showed earlier from the National Comorbidity Survey, you have much higher disorders, presence of the ADHD on psychiatric disorder and other psychiatric disorders, and you have much higher prevalence of psychiatric diseases on ADHD. So this is because ADHD is a neurodevelopmental disorder that has manifestations that change over the lifespan. At the beginning of life, what it is the most prominent is usually the hyperactivity. So children and adolescents who don't have the hyperactive type of ADHD are actually more difficult to diagnose. And they may account for the bias that we have, that we diagnose a lot more boys than girls, even though we know that as they progress in age, we see more girls with ADHD. Is this true, or is this, a result of our bias to not diagnose easily what is not disruptive? But you can see here that the hyperactivity as time goes by throughout the lifespan becomes more a subjective sense of restlessness and a kind of a sense of a discomfort with sitting still or with doing activities that require, focus over a long time. But the behavioral component, such as the hyperactivity, again, the hyperactivity and the impulsivity, in a way, they do respond to a certain extent to life. They do respond to sort of the frame that we put around children. And as adults, they learn that maybe they should, withhold their thoughts and not say everything, blurt everything out loud the moment the question is asked or before the question is asked. However, the component of attention remains the same and does not get corrected. What changes is that we can teach children and adolescents behaviors, and we can teach them ways to compensate. There are certain today, and I don't think I'll have the time, but there are some ways that are promising in terms of neurofeedback that they may be more generalizable in the future. They don't seem to be generalizable treatments right now, but they may make a difference. And there are actually some, to come back to the previous talk about the gaming, there are some, we have a game that's been approved now for kids with ADHD. So there are some new ways of looking, how do we moderate and how do we change some of the behaviors across the lifespan. But again, it is still not completely and fully generalizable for attention. Now, as you see, in terms of anxiety disorders or in terms of truly comorbid mood disorders, they could increase over the lifespan. And this is more due to the fact that, first of all, the internalized self-perceptions of the person change over time and they become worse. So that increases anxiety and increases depressive feelings. On the other hand, as time goes by, the negative experience also increase. So in terms of epigenetics, they're not very well placed, ADHD patients, and they often get early into the trajectory of mental illness, and they unfortunately stay there. So we have a lot of work to do to prevent this trajectory. Here, you can see some of the specific comorbidities and how they change in prevalence with age. So you see that some of the true comorbidities, such as anxiety, for example, a true comorbidity, is there present from childhood. And in fact, it can increase in adulthood because of some of the epigenetic factors and because of the negative experiences, especially if it is not treated. Depression, of course, depression is more manifested in adult life, but again, the difficult experiences play a significant role. The learning disabilities, a true neurodevelopmental disorder, is there and is stable in terms of prevalence across the lifespan. Oppositional defiant disorder is a construct that it is a lot discussed in child and adolescent psychiatry. As you see, this is, is this part of just a behavioral manifestation that, of course, is modifiable because we live and learn. Conduct disorder is quite stable, and we know that it's a disorder that also has a lot to do with genetics. In fact, one of the most important factors for conduct disorder is presence of antisocial personality disorder in the father. But obviously the impulsivity of ADHD and the difficulty of tolerating distress are factors that can coexist and can enhance conduct disorder. What is interesting is substance use disorder is more related to, on ADHD and addiction, is more related to co-presence of conduct disorder rather than to the severity of the ADHD itself. In terms of bipolar disorder, there is a lot of studies, and there are many interesting research projects that have started. The Smoky Mountain study, that is a large cohort looking at young people and looking at the manifestation of long-standing dysthyming presence in children and adolescents with a concurrent episodic presence of mood dysregulation. It was examined for many years, but there does not seem to be bipolar disorder that is the result of ADHD, because it was looked at as a comorbidity. Of course, all the data is not out, because for DMDD, we're still, the studies that have been done by both Stringaris and Lubiloft are both retrospective studies, so the prospective data is still to come. But the autism spectrum disorder, another neurodevelopmental disorder, for DSM-5, and rightfully so, can coexist with ADHD. Tic disorders, also neurodevelopmental disorder, can coexist with ADHD. Borderline personality disorder, to what extent the chaotic life that ADHD experiences provide for child and adolescent lead them to personality pattern that is borderline personality disorder is questionable, but there seems to be a relationship in adulthood. And obsessive compulsive disorder has to be distinguished from obsessive behaviors, as I said a little earlier. So here you see the overlap of symptoms of ADHD and comorbidities, some of the mood disorders. So in major depressive disorder, restlessness and agitation can coexist, difficulty concentrating, of course, all the attention and decreased attention. In conduct disorder, impulsivity and mood swings with anger outbursts are there. Bipolar disorder in hypomanic phase can basically share everything, but of course we have to remember that bipolar disorder is clearly episodic, as opposed to ADHD, which is not episodic and is there present from early life. Anxiety disorder shares the restlessness and agitation, and shares some of the difficulty concentrating and, of course, decreased attention, because if we're anxious and distressed, we're not concentrating, we're not capable to concentrate, and can also share some of the mood manifestations. And substance use disorder shares the hyperactive piece and the impulsive piece. Of course, the difficulty concentrating could relate to the substance or could relate to the person. And sleep disorders are very, very important to differentiate it, because they're both part of the ADHD as well as making ADHD worse. So some of the therapeutic approaches, ADHD and depression, well, it is very important to know that when they coexist, we operationalize the problem and we treat what is the most serious first. And this is, obviously very important to collaborate with the patient and the family and make sure what is their priority, what bothers them the most, and then look at the psychopharmacology or at the type, especially, or the type of interventions that we want to propose. So for children and adolescents, no specific therapies. Psychotherapy is the number one. In fact, it is well shown that both for anxiety and depression, the psychotherapy is for moderate anxiety and depression. Psychotherapy is actually the first solution, and there are types of psychotherapy that have been demonstrated to work very well, such as cognitive behavioral therapy, interpersonal therapy, and of course, depending family therapy. Both supportive and psychodynamic are also part of the what should be offered, in addition to medication. Now, when we're talking about treatment, we should know that, of course, to the extent and to the degree that the problem of attention is the result of the mood disorder, with an antidepressant, it is going to improve, but not all of it. And if we see that there is attention deficit that is not improving because of the comorbidity with ADHD, we should not be afraid to use stimulants, which are the best for attention. In fact, we should avoid, in the presence of SSRIs, atomoxetine, because it is an SSRI by structure, so it can cause serotonin syndrome. But in anxiety, as I will come back later, it is very good for the comorbidity of anxiety and ADHD. Now, tricyclics may be good for adults, but they're not good for children. In fact, Barbara Geller showed more than 20 years ago that we had a number of deaths from prolonged QT, and they're out of the question for children and adolescents unless everything else has been tried and failed. Bupropion can help for the two, not as good for attention deficit, and definitely third line, not first or second line for children. For adults who may be dealing with addiction issues, it is an interesting option. Antidepressant and stimulants can be safe together as long as we take caution. So in terms of ADHD and anxiety, this is an algorithm for children from Plitzka, from the Orange Journal. Basically, what it says is that we operationalize with the family and the patient the treatment plan, and we start with non-pharmacological treatments that are psychotherapies and specific psychotherapies. If we need medication, then we can choose, depending on the severity, which is the most important symptom, and we can go either, if we want to address both together, to atomoxetine, which is a weaker medication, takes few weeks to work. And of course, in terms of attention, we may not have so good improvement. So we may actually, after atomoxetine, still need to use a stimulant. But if somebody responds, it's a good medication. Or we can start with a stimulant and go the other way around, the other road. So if there is improvement of the ADHD, but not of the anxiety, we can add an SSRI at that point. Or if there is improvement, or we can actually add another, go back to atomoxetine as a trial, which can address both. In terms of ADHD and bipolar disorder, the coexistence appears to be associated with more severe impairment, a worse outcome for both conditions. So, of course, we treat the most severe first, so we stabilize for the bipolar disorder. Now, if the patients have relevant symptoms of ADHD after the stabilization and remains dysfunctional, then we need to treat, of course, the ADHD symptoms. Now, utilization of psychostimulants and atomoxetine are effective, but the patient should be stabilized, and we should make sure that the patient is stabilized before we use them, even though there is no evidence that they will cause a manic episode. But again, atomoxetine has the structure of an SSRI, and there are not enough studies, so we have to be careful with that. And as a summary, we have to look at the shared features. In fact, some of the scales that we use to, the youth, to the younger mania rating scale, for example, for mania, and at the same time we use the SNAP or the Connors for ADHD. And as we treat, make sure that we also complete the scales. There are multiple scales that are self-rated and observer-rated, and we should use them. They are very helpful, especially to help us see in terms of the medication how far we are to the optimal result. But the bottom line is, in terms of treatment, that we want to treat what is most severe, what is a priority for the patient and the family first. Make sure in terms of drug interaction, and provide psychosocial treatment and intervention. The younger the child, the more the psychosocial intervention and the more the family intervention. In fact, for young children, it is very important that the parents understand what to do and how to address the child's problem, and that is quite significant. The older, or for adults, we actually treat, and in fact we have right now a CIHR grant from Health Canada to look into an intervention of cognitive behavioral therapy and skills for adolescents with ADHD. We've done the same study with adults. It has shown a very, very good results, regardless of use of medication, to help them better cope, because these skills can be learned and they are complementary to medication. So for personality disorders, well, it must be treated separately. Treating the symptoms of ADHD may not alter the personality disorder, but may help patients have a better life. And it can facilitate an intervention for their personality disorder because they become more capable of doing that. And for obsessive compulsive disorder, again, we have to make sure that it is an obsessive compulsive disorder. So Brown-Yale scales, Y-box, etc., helps a lot in seeing the improvement on either of them. And of course, for substance use disorder, it has to be treated because it gets worse with ADHD and it worsens the ADHD consequences. And long-acting psychostimulants are extremely important, even though I have to tell you that there is no psychostimulant that I haven't seen being abused, even the ones that are not supposedly abusable. There are all these ways that our patients find daily to, or discover to sort of use our medication. So have to be very, very cautious. So finally, the key points, 50 to 90% of children, more than 85% of adults with ADHD have other comorbidities. Some comorbid conditions, such as depression, increase in frequency with age, as others that are probably truly comorbid in the neurodevelopmental spectrum, they remain the same, on the same prevalence over time. But even for these situations, there are ways to address them, either with medication or with psychosocial treatments, namely psychotherapy and skill development, that can help the patient actually function to their full potential. There is significant overlap between symptoms of ADHD and other psychiatric disorders, and we should screen for that, especially if we don't see very good improvement. And there are different recommendations from different bodies for the treatment of ADHD with with comorbid, other comorbid conditions. And thank you very much. And we'll go to the next presentation. So I would like to invite Dr. Latusakis or Dr. Limberis is next. Yes, Dr. Limberis, Dr. Maria Limberis, if you can. Perfect.
Well, in the interest of the ancient a healthy mind in a healthy body, I suggest everybody get up and stretch, okay? Let's just do that and just step a little bit with your legs because we've been sitting for too long and that is against your mental health. Okay, thank you. I am honored to be here And I'm delighted to be speaking at this time because the people who preceded me gave such wonderful presentations. And I have a comment to make that I tell my Chinese students. I've been teaching through Zoom in China psychoanalytic psychotherapy for over 8 years by Zoom. So the pandemic came and I was delighted because now I could be at home with my aging husband who was losing it. He was falling for the last 8 years. And the last time I was in Thessaloniki as the founder of the Hellenic American Psychiatric Association under the APA that I carried for 20 years until the proud Hellenic physician, Dr. Karamboutakis from Athens and Dr. Pangalos from Thessaloniki, he's a military psychiatrist, came to New York and they took it over. And I felt one more child of mine is launched. And the burden of care that women carry has been lifted. But the biggest event of my life was taking care of my husband, the end phase of his 12 years of gradually falling. It was like watching one of the Greek temples in slow motion disintegrate. You know, last time I was in Thessaloniki, I was here, but I wasn't really here because I had left him in Los Angeles, and bless his soul, he managed on his own with very few people and our son and our 2 granddaughters there on his own for the time I was here. But I didn't see anything in Thessaloniki except what I came to do. Well, this time I visited your museums, and what do you think impressed me? Most of the items in the museums are from graves. And it made me think how my talk about the end of life fit. Because now the latest is getting your remains, and I'm blocking the word, cremated. And the cremation is not the way the ancients did it. The ancients cremated, but saved the bones. And the discovery of Philip of Macedonia can show you where he was injured. You could see it in the skeleton. But now all I have is a box with the remains of my husband. So it made me realize my experience with my husband that I am here to share. And the objectives really is what I'm talking about. I was with him in total denial for 10 years that he was, in fact, heading to his death by falling and having a head injury. We are going to be living longer, and we have to be very careful about falling, because the end occurs only when your brain gets affected. My husband had his first brain injury when he fell on the 2nd of February, 2020. And within a few weeks, the pandemic happened and everything closed down. And I was greatly relieved because I didn't have to go to the office. And I could just do my entire work at home and take good care of him with the visiting nurse that came for about 2 months. And then we managed on our own. Of course, he hated to leave the house. Do we have to go? And yes, we do have to go out to dinner. And where do we go to dinner? We go to Platea. And where the hell is Platea? Platea is at the UCLA brand new Laskin Convention Center. And now UCLA breeds its own Nobel Prize winners. And the latest is a woman who studied the life cycles of black holes. I'm sorry, I can't remember her name, but it took a woman to study the black hole life cycle. Can you imagine? In any event, I was fascinated with that, but we were in complete denial. But when the brain injury happened, the recommendation of the staff was that I send him to a nursing home. I would send my husband to a nursing home? Are you kidding? For me, my husband was my mother, my father, my brother. I left them all when I was 16. I was going to put my husband in a nursing home. What am I going to do? And then the pandemic happened. Well, by March, beware of the House of March, of the 18th, he fell after the doctor visit. It was very fascinating. And I want to share this with all of you, especially the lovely woman who is an internist from Australia, right? The cardiologist, a great guy, took his blood pressure. Standing up, it dropped to 70. Now, my husband was over 6 feet high, and he didn't fall, but he did fall at home and got a second subdural, which left him not being able to move. At that point, I knew he was dying because I used to be a neurologist before I became a psychiatrist. And I remember there was a fight between the neurologist and the neurosurgeons who wanted to do bear holes to pull out the blood clots from elderly men like my husband. And the neurologists wouldn't let them touch them. And of course, I knew this was going to be the finale. And then to my great surprise, within a month, my husband turned to me and said, I didn't see it coming. Now, he's a motorcyclist and a mountain bicyclist. I didn't see it coming means death is here. Because if you're a motorcyclist and you don't see the cars coming, your history very quickly. Within less than 15 days, my husband was dead. And that was the time when I signed the papers for hospice. Up until that time, I observed the following. The convalescent, quote, hospital is not the acute unit. They were full of patients in various stages of dying. How many people do you think had visitors? What do you think? About 1 or 2? 0. You're absolutely correct. I was the only one, and what I was doing rounds because I used to have psychiatric patients, and I used to go in the morning. I used to talk with the staff midday, and I used to see them at night. So I did the same thing. And guess that helped my husband become conscious that he was dying. But look how long it took. Now, what I observed is, and there's nothing wrong, that it is life-saving after the awareness that I'm dying, then the meds are turned off, and then you really need the opiates. And it makes it possible. But to me, I saw another dimension of human life. I now feel that there are 4 dimensions. There is the biology, and you heard a wonderful example of ADHD, even though it didn't go into the networks in the brain. Then it is the emotional side, and you got a terrific presentation with ADHD and the comorbidities. But all of these diagnoses are statistical. We still do not know the pathophysiology of the words we're using, and you have to keep that in mind. The third is cognitive. There is hardly any serious psychiatric dysfunction that isn't accompanied by some degree of a cognitive dysfunction. But first things first, and we don't usually address that. And then I call it the spiritual dimension. I literally felt, I saw his spirit give up and say, you know, this body is done. It's done. It's failed. And he let go. And it's the last breath. So now I feel there are 4 dimensions. And to my great surprise, early today, I attended the opening ceremony. And guess what the Greeks have done? They had the head of theology get together with the head of law and the head of medicine. And they got together to sponsor the Aristotle Medical Forum. I mean, that is fantastic. It's inspirational. And it isn't religion. It is the spiritual dimension of our humanity. And we really need to bring all of that and help the family accept death. Not all patients are ready to do that, but a lot of the family can. And this can prevent the subsequent problem, because death for the person is over. The real problem of death is for the living, not for the dead. The dead are done. It's us who are left who have to clean up all kinds of the medical legal dimensions of our humanity, not to mention the family relationships. Now, what does all that have to do with climate change? Well, I now feel that life is the gift our parents give us. But you know, beware of Greeks bearing gifts, right? That's how Troy fell. It was the Durius Hippos. So what is the deal? You get a life, but you come with expectations. And I feel I made it to age 83, and I no longer owe my parents. I've paid the deal that they sent me for. So from here on, it's my life on my terms. It takes a very long time to get there, but if you do it well enough, it really works. Practice what you practice in your office, and you will do very well. Thank you for the pleasure and the honor.
So I would like to ask Dr. Latousakis.
Thank you for the invitation. I am the unit chief of a geropsych unit at the New York Presbyterian Hospital in New York City, and my talk today is focused on a specific disorder that is of interest to me and is quite frequently seen in inpatient psychiatric units, especially those that have to do with the elderly. I'm going to briefly touch upon the epidemiology, the pathogenesis, diagnosis, the acute treatment, and the maintenance treatment. Please bear in mind, this talk is focused on the psychotic depression, on unipolar major depression with psychotic features. And that particular type of depression is seen in about 0.4 to 0.5% in the general population, but the rates, of course, climb significantly when we focus on the patients with unipolar major depression, and it almost reaches 50%, 42 to be exact, among patients who are hospitalized with unipolar major depression. And of course, this particular type is the type that is associated with delusions and or hallucinations. That is the defining part of the psychosis. The psychotic depression is not just another form of depression. It is most commonly associated with higher severity in the symptomatology, in any way you measure it. And the psychotic features, which is, of course, the defining part of what we are talking about, are missed very often. They are subtle, they are intermittent, they are very actively concealed, actually, by patients, and they are perceived as non-delusional not only by patients and families, but also by the mental health professionals. And it comes with a significant cost. That particular type of depression is associated with a significant suicidality. In the current sample of patients with unipolar major depression with psychosis, you find suicidal attempts in about a quarter of the patients. And the associations are stronger with male gender, of course, past suicidal attempts, the total severity of the symptomatology, and specifically the content of the delusional component, especially when it relates to guilt. Frequently, anxiety is comorbid in various forms, and overall, this particular type has a much worse course of illness. You have lower remission and higher relapse rates. This particular slide tries to talk a little bit more about why is it difficult to study and treat psychotic depression. And perhaps the most important difficulty stems from the fact that patients and families do not recognize various ruminations that can take various forms. They are not recognized as irrational. The patient denies those symptoms and guards against them, especially when that delusional content is clinicians are trying to elicit it. The conviction that the delusional component is valid limits the treatment seeking and adherence, especially to the antipsychotics. And that is also related to the underlying lack of insight, which increases the likelihood of adherence. So ways to protect against that is to use multiple sources of information, and also to perhaps hone the skills of how to elicit information from the patient, using terms that are a little bit easier for them to not only understand but accept. Things that I have found helpful really include words like, tell me about things that dominate your thinking. Tell me about worries that seem to be pretty much pushing away everything else in your current way of thinking about things. Moving fast to the treatment side of things, of course, the two main tools remain ECT and pharmacotherapy, specifically the combination of an antidepressant and antipsychotic. The current level of evidence supported by a recent Cochrane review is that the combination is more effective than either monotherapy and, of course, placebo. I'm not sure whether people in the audience find this particular slide superfluous, but even today, many people who practice inpatient psychiatry are not convinced that this is actually the case. These are the 5 combinations that have been shown to be effective. And they are not exhaustive, but those are the ones that actually have the most evidence-based. The first one is the combination that was used by 2 studies funded by the National Institute of Mental Health. I was the research psychiatrist in one of the sites, the STOP-PD1 and STOP-PD2 trials. In both of them, the combination of sertraline and olanzapine was used, but other SSRIs like fluoxetine or even SNRIs like venlafaxine can be used. There are combinations that include tricyclics, amitriptyline, which, as psychopharmacologists in the audience know, have both serotonergic and noradrenergic effects, and first-generation antipsychotics like haloperidol and phenazine, trilafone. So with the combination of Zoloft and sertraline and olanzapine, we usually have a pretty strict way of titrating that, and we want to make sure that we go slowly, especially with the elderly, but actually get there. We aim for a dose of 150 milligrams of Zoloft and 15 milligrams of olanzapine by the end of the second week, and the maximum dose is listed in the final line, 220. The adverse effects that we have seen with this specific combination, of course, include weight gain, sedation, orthostasis, falls, and significant increases in various vascular risk factors, including cholesterol, triglycerides, and glucose. ECT remains a very important tool, and it has been associated with, remarkable effectiveness. This particular way of treatment is preferable when things are urgent, either because of suicidality or failure to thrive, and it is associated with, as I said, pretty robust remission rates. There is actually evidence that it may be more effective in unipolar major depression that has psychotic features than the unipolar major depression without it. The remission of the 2 forms are listed there, the remission rates as well as the response rates. And in general, it's considered generally a safe mode of treatment. So in the acute treatment, we want to make sure that we treat at least for 4 to 8 weeks at minimum target doses. And if the combination that we initially choose is ineffective or not well tolerated, then of course we have to switch to something else, and the other 4 combinations that have evidence and evidence base are listed there. So the steps that you see here are the ones that we take if pharmacotherapy is not effective. We have the option of switching to ECT and vice versa. If we start with ECT, switching to combination pharmacotherapy, and different selections of antidepressants and antipsychotics. And then the last bullet there, lithium and psychotherapy, are less studied for this particular type of depression, but they are recognized and definitely at the level of case studies, they have shown to be valuable. So in terms of time to recovery, it's useful to know those numbers, and it's useful to educate the patient and the family in advance. 50% of patients recover within 2 to 3 months. The large majority will recover by half or 1 year, and time to recovery actually may be worse than the unipolar major depression without psychotic features. And functional recovery lags behind symptomatic. So maintenance treatment, which was what the second study I mentioned before was focused on, is of course indicated for all patients who remit. The combination that led to the initial remission or near remission has to be maintained for at least 4 to 6 months. And I'm going to skip the rest of the bullets. Apart from the maintenance of the antidepressant longer than the antipsychotics, that the aim in the maintenance phase is to actually taper the antipsychotics slowly over 1 month, but not within the first 4 to 6 month period. Of course, you are always very, you stand ready to restart the antipsychotic if you see any return of symptoms, and you aim for the antidepressant to stay on board for at least 2 years, and in some cases, depending on the individual case, for as long as the patient's lifetime. Things to consider when you make that decision include, of course, residual symptoms, history of suicidal attempts, other comorbidities, and the number of type of previous major depressive episodes. This is the reason that I chose this particular topic to start with, the fact that this type of depression that we are not very good at diagnosing is actually pretty pernicious. It is associated with more recurrences, more readmissions among previously hospitalized patients, a higher mortality rate, greater disability, and greater use of services. My time is up, so I'm going to skip some of those slides. The STOP PD, the first one that we did was focusing on the acute phase, and it was associated with 42% intent to treat remission rate, and that jumped up to 67% for the completers, with the issues of increases in weight and lipids that I mentioned before. Something that we have found discussing with other psychiatrists often is whether an SNRI is actually more effective than an SSRI, which still is not actually something that has been clearly concluded. The last slide I'm going to show, since my time is up, is that there is a way to include a semi-structured interview to assess the patient's ability to reality test and accommodate to contrary evidence when you try to elicit the psychotic component in complaints that may sound rational or quasi-rational, and the use, of course, of all possible sources of information. One specific question has to do with whether that person actually acted on the belief. These are the results of the second part, the one that focused on the maintenance, and it clearly showed that patients who were maintained on the combination had much less risk of relapse. The problems with olanzapine is, of course, primarily weight gain and metabolic problems. During the period of time of the 36 weeks, they gained another 2.6 kilograms on top of the 5.4 kilograms that they gained in the open label phase. I'm going to conclude with those few bullets. Psychotic depression remains heavily understudied, in sharp contrast with a disproportionate toll in suffering, quality of life, and issues of course of illness and response to treatment, mortality. Combination therapy is more effective than either monotherapy or placebo, and that evidence is accumulating for both the acute as well as the maintenance phase, how to treat them. Thank you so much.
Thank you very much, Dr. Latoussakis. So, Professor Paxinos, your turn. Thank you very much. Looking forward to hearing from you.
Καλησπέρα. Now, if I could ask you the favor to give a standing ovation to Dr. Latoussakis and at the same time exercise your legs. Why psychology lost its soul? I have been an atlas maker, as Lila mentioned, and indeed it's the 40th year of the publication of the rat brain stereotaxic coordinates. This is not always a good thing. Recently, I met a lady who had used the atlas as an undergraduate to do her undergraduate thesis, and early on, 40 years ago, and she said, "George Paxinos, I thought you were dead." The work we did with maps of the brain was made possible courtesy acetylcholinesterase and other enzymes, neurotransmitter receptors, neuroactive compounds. And you can see here that the brain, the amygdala and the basal ganglia of the monkey looks as though it has been a coloring-in book that has been colored in already. And that I noticed in sabbatical at Cambridge, and I thought I would do an atlas even though I was only a psychologist. But I paired with Charles Watson, and we've been working since then. This year we published an atlas of the spinal cord. And it used to be said, the gain in the brain is mainly in the stain. The talk today is about why psychology lost its soul, but I'll tell you a little bit through the process of making the maps and figuring out some things about the brain. And you can see the similarity externally to us. After doing an atlas of the rat, I thought I would try an atlas of the human brain. But I first wanted to try non-human primates so that I would get to know what to expect in the human brain. Because the human brain, you get 8 hours post-mortem, by which time enzymes are degraded. And I didn't have a chimpanzee to show you. Didn't pose for me, but I show you orangutan instead. But you could see the similarity to us. I actually externally, internally, it's likewise. And I wrote to the Taronga Park Zoo to give me the opportunity to do a postmortem on a chimpanzee brain once a chimpanzee died. They responded they would be happy to oblige, but they had not had the death of a chimpanzee in the zoo for a decade. 2 months after receiving my letter, 3 chimpanzees died. Luckily, they didn't suspect me, and I studied the brain of one of them. That led us to study, to do a work on the human brain stem that you see here. And indeed, there's nothing that we found different in the human brain from the chimpanzee brain. All is homologous. The chimpanzee brain, of course, is half the size of the human brain, 600 grams, and the chimpanzee is nearly our weight, 60 kilos. After doing work on histology, we are trying now to see what we can see from imaging. And you can see here from work we did in the rat with imaging, and you have the advantage of seeing connectivity with MRI. But the work really that we're doing now is on the human brain, and you can see it here. Firstly, in postmortem tissue connectivity, and you can see the corticospinal tract in blue, the pontocerebellar tract in red. And the thing that we're really doing is we just started this, we hope to we got the data, which is the most important part of anything. We haven't analyzed the data, is to look at the living human brain. And what you see here is the work we're doing on one of us, one of the 3 authors of this work, subjected himself to 20 hours in the magnet over various times, and we obtained what we think is as good imaging data as anyone. In the next year, we hope to publish this work, and you can see not only a structure in this, but also some of the connectivity. And we hope that we'll be able to identify all those structures that we identified in histological tissue, with the advantage of having the native stereotaxic space not distorted by pulling the tissue on slides. And now on the brain, I need to convince you first that the brain is important. And you can see here an astoundingly modern view by Hippocrates. Men ought to know that from the brain and from the brain only arise our pleasures, joys, laughter, and jests, as well as our sorrows, pain, griefs, and tears. Nobody has said it better since then. And but this was not always appreciated, of course. The ancient Egyptians heedlessly discarded the brain in funerary practices and sent millennia of pharaohs brainless to their afterlife. In Shakespeare, you can see even then the fight was between the cardiocentric view of Aristotle, and I can't say too many bad things about him here in this forum, and Hippocrates or Galen, subsequently, who took the fight, the encephalocentric view. In Shakespeare, Portia asks in The Merchant of Venice, "Tell me, where is fancy, love, bred, or in the heart, or in the head?" Now, science has proven unequivocally that's the brain. But when I went to Bondi Junction in Sydney to pick up a card for my girlfriend, I was confronted with 300 cards with at least one red heart on them, none of them with the brain. And my hand was forced to write an article, "Darling, I love you from the bottom of my brain." And I received a call from the Australian Broadcasting Corporation in Melbourne. The lady asked me, "Are you insisting that the heart has nothing to do with love?" I said, "If in a heart transplant I get your heart, I am not going to fall in love with your husband." And she said, "What a pity, and he's such a lovely man." After such a battle to localize the seat of the soul, psychology loses its soul. Gave a talk to clinical neuropsychologist in Australia, and before giving the talk, I went around and asked, do you have a soul? And always the answer was, pardon me? I couldn't believe the question. But one person finally said to me, I did, until I started my PhD. And the mind is the integration of the activity of the brain. There's no ghost in the machine. Now, poor humans, look, there's no need for the soul. For scientific considerations, if the soul is where emotion and motivation reside, where mental activity occurs, where sensations are perceived, memories are stored, reasoning takes place, and decisions are made, love is manufactured, then there's no need to hypothesize its existence. There's an organ that already performs these functions. So psychology tells you soul is superfluous to requirements. Skinner tells you, well, the question then, is there anything left in us? What about free will? Are we really have any agency at all? And Skinner tells you, and most neuroscientists, no, none at all. Behavior is the outcome of the genetic endowment we receive and the environmental influences on that endowment. And we don't choose our parents, and we do not choose what our mother was drinking while she was pregnant with us, our early environment, or the later environment when we come out in what society we're born. And in that concept of some neuroscientists believe this way, of course, the others who don't, and we don't know, we don't settle scores by majority vote in this business, but in this view of neuroscientists, environment sculpts character, just as this unknown artist, possibly Phidias, sculpted Apollo from Parian marble in the statue from the Temple of Zeus in Olympia, just like Praxiteles sculpted Hermes, so that the environment sculpts our character from the genes we are endowed. That is, we are genes sculpted by the environment. So the brain is important. I hope you're already convinced, perhaps without me saying this, of the view of Hippocrates. And it is the puppeteer. The mind is just a puppet, has no agency. And then it's good to know whether the brain is the right size. There is this zone around the sun that is habitable, and is this Goldilocks zone. In my view, the brain is anywhere but the Goldilocks zone. If the brain was smaller, less clever, and incapable of language than what it is, it would not have been able to produce the science and technology which today threaten existence. If the brain was larger than what it is, humans might have been able to comprehend the problem, even rectify it. The brain is just not the right size. And poor humans, we think we suffer from a triple delusion. We think we have a soul. Well, no evidence for that. We think we have free will. Again, there's no indication of that, at least according to some neuroscientists, the majority, I think. And the third delusion, they think that they are made in the image of God. The chimpanzee, in terms of the brain, I think it's far more credible. And the ancients didn't have a good view of those who claimed that they were godlike. Look at poor Sisyphus pushing a rock uphill only to fall down and having to push back again. I told my granddaughter that the gods punished this person to push the rock up the hill again the next day. She's 8 years old. And because I said this king of Corinth, he was narcissistic, he was egotistical and insulting. And she said, like Trump. And I am hoping that we'll reject this triple delusion, and armed with the truth, and realize that we, as E.O. Wilson said, we don't know why we're here. Puzzled we stand before nature. We have leftovers in our brain of the reptilian period. We have Paleolithic emotions. We have medieval institutions and a technology that threatens our own existence and that of other beings, and in the hands of Putin and Trump and Kim Il-sung. And if only we understand our delusion to know thyself, gnosis avton, to know thyself, then we might change our, set our stern to the dawn and not to the grave of our children, and make wings of our oars. And that made me work for the last 21 years to write a novel so that I could alert, if anyone might read it, of where we are, what we are. So A River Divided is the novel. Neuroscience principles were used in formation of characters, such as those related to the mind, soul, free will, and consciousness. Environmental issues are at the center of the novel, including the question of whether the brain is the right size for survival. Characters in the novel speak directly of the principles of neuroscience, as Professor Eastbrook does, or demonstrate these principles, as for example, when they never display free will. You will not miss it if you look at it. And it's A River Divided. It's the Amazon. And Rio Salamos and Rio Negro, they derive from different places, and they have different catchment areas, that is, different color, different acidity, different temperature. Their destiny is the same, and the story is about identical twins raised apart following a discovery in Israel, and a cloning of that person that was discovered. They will meet for one, they are raised apart, they don't know their heritage or the existence of each other, and they will meet for one moment only in the Amazon, adversaries in the battle to save the environment. And it is this one, and in Greek, just came out last week. And Magdalene, that's sweet of you. If you haven't given up, that means something good for me. Thank you. Yeah, and is there any? I guess the question session now. Thank you for listening to me.
Thank you very much. I think our time is up. I'm not sure. I think it was extremely rich, everything we heard, and especially very, very much thought-provoking. But our time is really up, so I think we have to continue. Do we get 15 minutes, or I think we should get a few minutes to go out and get some
Maybe
water?
anybody that wants,
or-
any questions, any burning questions, maybe you meet us outside. I don't think we should take any more time from the next session before they kick us out by force.
So please take a few minutes and come back for the next session. Thank you.
Oh, hello, everybody. I am Fawzia El Tamimi, a dermatologist from Ain Shams University, Cairo, Egypt. First, I wanted to say that I'm honored and I'm very proud to be a part of the forum, as it's my first participation in a Greek medical event. So our session is about dermatology, phlebology, and cancer prevention. I will talk about the misconceptions about sunscreen and sun safety. So we will talk about the solar radiation. The sunlight reaching the surface of the Earth contains visible rays, ultraviolet rays, and infrared rays. We will gonna talk about the ultraviolet rays. So the ultraviolet rays, although they are only 5% of the sunlight, they are responsible for the most damage of the skin. So UVA, UVB, and UVC. UVA and UVB are UVA indirectly induces skin cancer, and UVB directly induces skin cancer. Again, UVA, UVB, and UVC. UVC, fortunately, is completely blocked from the ozone layer, but UVA and UVB is not blocked from the ozone layer or from the clouds or through the window glass in our car. So it causes DNA damage and skin cancer. UVA, the effect is deep in the dermis. Artificial uses are the tanning beds. The UVB is more superficial on the epidermis. We use them in the fluorescent lumps, and of course, it causes sunburns. So there are factors that affect the UV radiation. The ozone, as we said, the time of the year, the time of the day, mostly from 10 to 4 p.m., the latitude, the altitude, and that's why the skiers and the snow sports, they need to, who play snow sports, they need to take care and they need to put sunscreen, and of course the weather condition. So there are short-term effects and long-term effects. The short-term effects, of course, is the sunburn, immunosuppression, and direct DNA damage. The long-term effects is epidermal thickening, skin cancer, photoaging, and pigmentary disorders. The sunburn is the most common and most acute effect. It is a protective mechanism to remove the irreversibly damaged skin cells after excess UV radiation. And as we said, the intensity is greater at high altitudes. That's why the skiers need to take extra care. What are the causes of skin aging? The causes of skin aging is intrinsic and extrinsic. Extrinsic is 80%, and the most important is chronic sun exposure. Also smoking and pollution. So this is a very interesting picture. He's a trucker for 28 years. His left side of the face, who faces the sun, is completely, it's damaged, it's sun damage. We can see the dry and rough skin, and it's thin and fragile with wrinkles. And the right side, which was protected, more protected, is much better. This is a 35-year-old melanoma survivor patient, and this is her face under UV camera. We all can see the damage, which is invisible. So what is photoaging? Photoaging is the premature aging of the skin. Wrinkles, actinic keratosis, which is very common and it's precancerous, rough sandpaper-like scaly spots, and solar lentigo. So all skin, no matter the color, thickens and hardens with continued sun exposure, resulting in wrinkles later in life. What about the skin cancers? The skin cancers, almost 8 out of 10 skin cancers is basal cell carcinoma and squamous cell carcinoma. And melanoma, of course, is the most serious one. So skin damage from radiation is cumulative. The more time spent unprotected in the sun over your lifetime, the greater the risks. And the annual statistics of WHO 2020 say that 1 in 5 people will develop skin cancer throughout their life. These are maps for males and females with malignant melanoma worldwide. Skin cancer cases were 1.5 million in 2020. This is the incidence, the mortality, which are huge numbers. And this is the non-melanoma skin cancer. Mortality were more than 120,000 people. Again, the incidence of non-melanoma skin cancer and the mortality. These are the skin cancers that are most common, and they're that common that they are often neglected. Melanoma, squamous cell carcinoma, and basal cell carcinoma. Scientists say that 50% of all skin cancers can be prevented by proper sun protection. And this is a very big number. It also causes effect on eyes. The UVA and UVB rays are absorbed by the lens and the retina, and they cause cataract and retinal injury. So we need, for a protection, we need blocking sunglasses, UV blocking sunglasses. As we all know, we have the melanin, our natural photoprotectant. The white skin allows UV rays to pass through 5 times more than the dark skin. So the average protection from our melanin, naturally, the dark skin is 13.4 SPF and white skin 3.4 SPF. So the SPF is the sun protection factor. The rate is calculated by comparing the amount of time needed to produce a sunburn on sunscreen protected skin and the amount of time needed to cause a sunburn on unprotected skin. So as an example, if a person takes 10 minutes to get burned with no sunscreen, a sunscreen with SPF of 15 means it would take 15 times longer to burn, or 150 minutes. Unfortunately, it's only for UVB. SPF does not measure UVA. So the sunscreens is #1 anti-aging ingredient. The 5 W's and H of sunscreens, who, everyone under the sun, except children less than 6 months, we can protect them with clothes and hats. But we need to choose broad spectrum, SPF minimum 30 or higher. And when? Every day, 30 minutes before going outdoors, and we have to reapply every 2 hours on all parts of our skin exposed to the sun. And of course, to reduce your skin, skin aging and skin cancer. So how much exactly to put? We need to calculate around 1 to 2 teaspoons or 2 finger lines for every part of our body, like face, neck, and ears, both arms, each leg, front of body, back of body, and please don't forget our ears and the back of the neck. So it's never too late to start applying sunscreen. The FDA-approved sunscreen filters, we have inorganic and organic. The inorganic is the titanium dioxide and zinc oxide, and all of them are protecting from UVB, but not all of them from UVA. So for the inorganic, it's absorbing and reflecting the UV radiation, but it's white, chalky white in the color, so sometimes it's aesthetically unacceptable. The good thing is that it doesn't cause irritation. The organic, the chemical, the bad thing is that it's toxic to coral reefs, adverse impacts on marine life, but it's transparent and it's more easy to use. Okay, we have the UV index. The UV index is from 1 to 11 plus. 1, 2, and 3 is good for us. We can go out when the UV index is that low. This is very good. But when it's higher than 3, it's very important to put sunscreen. There is an application, many applications on our mobiles, we can download them, that predicts the next day's UV levels on a scale. What about the tanning beds? The tanning beds, or cancer machine, as I name them. They are 15 times the UVA from sun, and they cause melanoma and cause squamous cell carcinoma and basal cell carcinoma. They actually cause 2.5 times more likely to develop squamous cell carcinoma and 1.5 times more likely to develop basal cell carcinoma. So is sunscreen 100% protective? No, of course not. We need long sleeves, we need hats, umbrellas, and sunglasses. So, some questions. If you use plenty of sunscreens, you can stay in the sun as long as you'd like. False. You need to reapply the sunscreen every 2 hours. You don't need to protect or cover your skin on cloudy days. False. UVA rays still penetrate through clouds, as we said. Which of the following surfaces reflects ultraviolet rays? Snow, sand, ice, water, all of the above. The answer is all of the above. Wearing white during hot weather protects you from sun damage because light color clothing reflects light rather than absorbing it. No, this is false. UV rays penetrate through lighter colored clothing. Wearing dark sunglasses is enough? No. Glasses should specifically state that they provide UVA and UVB protection. Sunbathing or sun tanning once in a while won't hurt your skin. False. Sun damage is cumulative over a lifetime. The darker your skin color, the less you need to worry about sun protection. False. Even darker skin types can get sun damage and skin cancer. Using sunscreen will decrease my vitamin D levels? This is a very common question. No. People who use sunscreen daily can maintain their vitamin D levels. So when we choose a sunscreen with a sun protection factor, which is the least number, 30. Thank you, and I wish everyone a great summer, but remember that when UV index is 3 or more, sun protection is required. So our second session is about skin manifestations of systemic disorder. Dr. Anastasia Therianou, consultant dermatologist in Imperial College NHS Trust, London, UK. Hello, Dr. Anastasia, can you hear us?
Yes, yes. Hello, thank you very much. I'm very honored and delighted to be here, but I'm also very jealous that I was not able to be in person with you, all of you there, and give that talk, and also enjoy the wonderful Thessaloniki. So let me share my screen. Can you see?
Yes.
Okay, sorry, just give me a minute. Okay, so I'm going to present about skin signs of systemic diseases. So how some of the diseases of the internal organs manifest to the skin. And many of us, when we hear the term dermatology or dermatologists, we think maybe it comes to our mind this image like a few spots, acne, or maybe we think about eczema, or maybe we think about Botox, and this is a before and after photo, or even laser hair removal. However, dermatology, it's much, more about that. So the aim of this talk is for the specialists to refresh their existing knowledge, and for trainees and medical students to demonstrate some main skin manifestations of internal diseases, and to be able to recognize these conditions when they are on call, or when they're doing, avorotiko. And maybe some of these conditions might come up in exams. For the non-medics, I'm not sure if there are many, I'm not able to see and ask to raise your hands who of you are non-medics in the audience, to realize that several systemic diseases can manifest to the skin, and that dermatology is not just about acne. And this is a lady who presented with some indurated, painful plaques, red on the lower legs. And this is an image at a closer look. And this is called erythema nodosum. Erythema nodosum is a form of panniculitis, panniculitis means inflammation of the fat. So the inflammation is under the skin. And we see this with red, raised, tender nodules, mainly on the shins, but we can see it also in other places. But this is the typical, usually it's on the shins. Affects female more than male patients. And why this happens? So could be a trigger from bacterial infections. Streptococcus, that's why I underlined this, is one of the most common triggers. Also sarcoidosis or inflammatory bowel diseases like Crohn's and ulcerative colitis can trigger this. Medications, contraceptives, for example, are one of the most common drugs that induce it, or pregnancy, or can be linked to internal cancers and lymphomas. Sometimes can be idiopathic. That means that, we don't find any cause, and, it just happens. And we do several tests like blood test, a throat swab to rule out Streptococcus, this bacterial infection. We do a chest x-ray, pregnancy test, obviously only in women. And the treatment is rest, leg elevation. We give some NSAIDs for the pain, and sometimes can be more complicated, but the treatment now is not, it's not our target to learn about the treatment, so I kept it simple. And then let's move on to another condition, which here you can see a target. And this is erythema multiforme. And why I put this photo of the target? Because the lesions look like targets. And this is a hypersensitivity reaction of the body to something. And what this something can be infections, 90% of the cases. The most common one is the herpes simple virus, type 1, so people with cold sores, or can be induced by drugs, or can also be idiopathic. But the most common one is infections, and can be minor, that is acute and self-limiting, and we can see just target lesions basically mainly on the palms and soles, and can be major, where we can see these target lesions, but also the mucosal membranes are affected. So we see involvement of the mouth, the eyes, and the genital area. And these are some examples. So this is how it looks on the palms, and this is on the body, and this is at the dorsum of the hand. They look, I put 3 of them just to show you that it's not exactly the same in all cases. Here, for example, at the center, it's a bit more raised. So these are called bullous erythema multiforme. And now this is another condition where on the left side, we see a lady that has a purplish rash on the eyelids, and this is called heliotrope rash, and because it looks purplish like the plant. And then on the hands, we see some purplish papules that are called Gottron's papules. And if we see at a closer look with a type of magnified glass called dermatoscope, or around on the nail folds, around in the skin around the nails, we see this thing that's called telangiectasias, that is dilated vessels. And also on the trunk, at the upper trunk, we see this like sunburn type of reaction, which obviously it's not sunburn, but it's related to this condition called dermatomyositis. This is a connective tissue disease. It's autoimmune, but people can have genetic predisposition, so there are some genes that are involved, can affect only the skin, but also can affect the muscles. So sometimes people say that they are having difficulty at climbing the stairs, lifting their arms, they feel fatigue. It's more common in female than male patients, can be linked to underlying cancers. In women, the most common ones are ovarian and breast cancer, while in men, it's lung and cancers of the stomach or the gut. In the blood, we check different things, but most of the 80% of the cases have some antibodies, the ANA antibodies positive. And we see also elevated muscle enzymes. The most sensitive but not specific for this disease is the CK. We also do scans. We investigate for underlying malignancies, and the management can be steroids, avoid sun exposure, and other immunosuppressive medications. And if you see at this photo, you might think, okay, this looks like an ulcer in somebody's lower leg, maybe it's a trauma. Or this is the same thing, it looks a bit different, but it's the same disease. This is called pyoderma gangrenosum, where we see it most on the trunk, but also on the lower lips, can be painful. And 50%, so half of the cases, is associated with inflammatory bowel diseases, rheumatoid arthritis, or multiple myeloma and leukemia. And here, this is like a velvety hyperpigmentation and thickening of the skin. On the right side, you see an axilla. On the left side, you see the back of the neck of someone. And this is called acanthosis nigricans, which is benign thickening of the neck and flexures, can be familiar, but very commonly can be associated with insulin resistance, obesity, and cancers. That's why people have to be investigated for diabetes, and we have to check the glucose levels. And let's move on to another entity called scleroderma. This scleroderma can be only a few thick. Scleroderma means in Greek hard skin, and can be only on the skin, and this is limited and doesn't affect the internal organs, but can also affect internal organs. And we have 70% of the cases are limited cutaneous systemic sclerosis, and 30% is diffuse, where more organs are affected. And this can be found, it's more common in people of African American origins. And what is CREST syndrome? These are initials of C for calcinosis. So you see somebody's finger that looks like a sausage, and it's accumulation of calcium under the skin. And on the right, on the top right side, we see Raynaud's. So the fingers are cold, they turn white, and can be painful with a cold temperature or cold water. And here on the bottom left side, we see sclerodactyly, where because of the thickening of the skin, there is difficulty in moving. And here at the face, we see telangiectasias that are dilated vessels, mainly on the face, cheeks and nose, but can also be found on the tongue. This has a more rapid onset and can affect, as I said, we have talked about the crest, and this is the diffuse systemic sclerosis, and can affect, apart from the skin, the gut, the lungs, the heart, and the kidney. That's important to be diagnosed early and be investigated, so people, know what they're having and to have the proper treatment. In their blood test, we check for anti-SCLE 70, which is an antibody. And there are various immunosuppressive treatments that are available for this condition. On the trunk can appear like this, and this is called pepper and salt sign, because if you see, there is lack of pigmentation on the skin, but the skin remains intact and normal around the hair follicles. That's why it gives this sign, and it looks like a pepper, and it's very typical. So these are the forms to summarize. As you see on the left side is the limited form, crest, and then the diffuse form. And then sometimes 20% of the cases can overlap with other diseases like lupus, arthritis, or other conditions, mostly autoimmune ones. And this is a lady with some indurated, so hard plaques, red plaques on cheeks and nose. And these indurated plaques on the lower legs that, as we have discussed, this is called erythema nodosum. It's the first condition we've spoken today. And this is an old scar which suddenly starts becoming more raised, red, and looks a bit, different. This lady also has cough, apart from these rashes. And what the chest X-ray was done, and it shows bilateral lymphadenopathy. So there is enlargement of the lymph nodes. And this is sarcoidosis. Sarcoidosis is a multi-system granulomatous disease. We don't know the etiology. Again, is more common in Afro-Caribbeans. More than 90% of the cases have a lung involvement. 20 to 35% of the cases have skin manifestations and can affect the lungs, eyes, liver, and all the other organs. And this can be treated with steroids and other immunosuppressants. And this is another example how sarcoidosis, because not all of them look the same, where we can see the induration, the infiltration. If you touch them, they feel hard to the touch. And the face is a common area where we see this. We do chest X-ray, bloods, the ESR and the ACs are raised, and also we see very often hypercalcemia. And the skin biopsy shows granulomas. And this is a lupus. So lupus is a broad term of a condition, of an autoimmune condition, and there are three types. It's the systemic lupus, the subacute cutaneous lupus erythematosus, and the discoid lupus. Again, it's more common in Afro-Caribbeans and Asians and affects female patients 9 times more than males. When it affects only the skin, this is the discoid lupus erythematosus, affects only the skin, and in 5% only of the cases, there is risk of involving other organs. We see this type of red plaque with a bit of scaling, and when this goes, it leaves like a scar, basically on the face, but also we can see scarring alopecia on the scalp. So the hair goes, and where the hair follicles were, it's substituted by scarring. It's important, these people, to avoid sun exposure, and there are treatments that can be done. The next entity, the second type of lupus, is the subacute cutaneous lupus erythematosus, where it doesn't cause scarring as the previous type. We see arthralgia to 50% of the cases can be associated with drugs, also with Sjogren's syndrome, and typically in the blood we see anti-Rho and antibodies positive. And this is an example. It's typical to see these annular lesions, so like rings across the trunk, and sometimes like plaques on the lower legs, like in this photo. I'm showing you with the arrow, which looks like psoriasis, but it's not psoriasis. Lupus, we call it, that is a great imitator. And the systemic lupus that can affect anything in the body. And the dopamine rush is, just to remember, dopamine is the acronym to remember what are the main things that we are looking for. So we are looking for a rash, oral ulcers, photosensitivity, arthritis. Malar rash is the rash on the face that is also called butterfly rash because of how it looks like the wings of the butterfly. And then many other, as you can see here. And this is the butterfly rash, which is red, and the people look as if they were sunburned, but they aren't. It's how systemic lupus is. And they have Raynaud's, that we discussed it already, what it is. They can have these blisters on the scalp, not only on the scalp, on the trunk. They can have this like net-looking rash on the lower legs or scarring alopecia. All these are parts of systemic lupus erythematosus. And finally, another disease where we see like a benign tumor on the top left side. It's called fibroma, which appears on the nails. And on the right side, we see some spots that they look like acne, but they are benign tumors of the skin called angiofibromas. And then we see this hypopigmented patch on the trunk, which looks like vitiligo, but it isn't. And then we see also this type of rash on the bottom right side. All these are part of tuberous sclerosis, which is a genetic disorder caused by mutations in TSC1 and TSC2 genes. In this case, why it's important to diagnose this, because usually the first signs come during the adolescence when on the skin. It's important because people can have benign tumors anywhere else in the body. They can have benign tumors in the brain, and this can cause epilepsy, later in life can cause learning difficulties, or they can have other benign tumors in the eyes or in the kidneys. So, to summarize, we have discussed, because there are many more other conditions, but we cannot discuss all of them, but these are the main ones, and how important it is for clinicians, not only dermatologists, but also other internists, to be able to have knowledge of these main conditions, as it's important to make an early diagnosis and treat the patients accordingly. And this is a tree where the tree of dermatology that demonstrates all the different types of skin and not only skin conditions that we see. Thank you very much.
Thank you so much for the very interesting topic.
Thank you.
So our third session is about next generation phlebology. Dr. Savas Apostolidis, vascular surgeon, phlebologist, Hellenic Medical Society of Hessen, Germany.
Okay. Kalispera, dear colleagues. I'm very glad to be here today and just relax and enjoy a practical presentation and a short presentation. Kavala, my birth city. And like the motto of this conference, I start with Hippocrates. Hippocrates wrote a book on ulcers, perielkon, and he mentioned the one treatment of varicose veins with puncture, but not surgery at this time. At some few centuries in the future, and there was in Ulm, Germany, Johannes Scultetus and his son, they published a book about surgical instruments, Armamentarium Chirurgicum. Here you can find some methods to treat varicose veins. Imagine no anesthesia was used at this time, and all these procedures had the same principle. Abuse the varicose veins on the lower leg in such a way that thrombosis caused an occlusion. In the 20th century, William Babcock in the USA published a very famous publication in the phlebology about the extirpation of varicose veins of the leg. 11 cases, most of them were patients with ulcers, and there was very good results in this publication. So it's come a few years ago, or a few decades ago. My teacher, Wolfgang Hach, he's 91 years old at this time, yet now, has some new aspects in phlebology. One of them was the recirculation circuits of primary varicose veins. Professor Hach also had a lot of efforts by doing the ascending press phlebography to have a new method for the diagnosis, for also the stage of the varicose veins. And then, first of all in Germany, he did surgery like stage adapted stripping, not like Babcock, who stripped all the vein, but he stripped only the varicose vein. What are the restrictions of surgery? First of all, the surgical trauma, the wound healing disorders, infections, nerve and lymphatic vessel lesions. You need an operating room, you need an anesthesiologist, and sometimes people have to stay in hospital, and if you have anticoagulants, you have to interrupt them. So at the beginning of the 21st century, we had new methods in the phlebology that were the endovenous thermal ablations. And we have three kinds of them. Radiofrequency was the first of all, then the laser ablation, and there's a third one who is not very common, is the stem vein sclerosis. What were the advantages, or what are the advantages of these procedures? They're minimally invasive. We don't need any incisions. No narcosis is needed, but most of the times, tumescence local anesthesia. You don't leave hematomas behind, and you have a faster mobilization. And there are modern methods that's very good for the marketing. But they have restrictions. One of them is the distance from the skin to the vein. You also have nerve damage, burning, or thrombosis, and you are not allowed to use these thermal procedures at the lower leg. You need to make some investment. But not in Greece. In Greece, you don't need this. You just have to pay for the materials you use. But all over the world, you have to make these investment costs. So, and there is some more new methods. There are the non-thermal endovenous procedures, like the sclerotherapy, that's the chemical ablation in liquid or foam. The glue, there are 3 glues on the market. The mechanochemical ablation is like Clarivane, and there's some very new catheter-based chemical ablation, the ScleroSafe platform. And all these methods, they have also some major advantages, like no anesthesia needed at all. There's no nerve damages. The varicose veins can be treated all over the leg. The patients don't have to stay in the hospital. You have very nice aesthetic results, and you can use these methods under anticoagulation. I would like to show you some videos from one method. That's the new kids on the block, ScleroSafe and the ScleroSafe with V-block. And what exactly is the new? The new is this new inverse action dual syringe, where you can inject the sclerosant into the vein through the one syringe, and simultaneously you can aspirate blood and the used foam to the second syringe. And you can do this only with one hand. You're going to watch this. What you need, just an ultrasound machine and these few materials. So the puncture and ultrasound control. It's not that easy every time, but I use, of course, the best video. Then you insert the guide wire through your needle, and then the catheter over the guide wire. The patient has no anesthesia, no local anesthesia, nothing at all. And he or she can watch the procedure anytime. Most of the patients don't like this. You can use it with liquid sclerosant or with foam. That's the way I produce foam in this syringe. And then you can do the sclerotherapy. And you see, I just need one hand for the syringe, and you have this inverse action inside, and you can watch the occlusion of the vein in the ultrasound. An animated action for better understanding. So you have less blood clot left behind, so it's more effective and aesthetical, very nice. That's my results from last year. I have treated 96 patients and had occlusion in 94% and partial occlusion in 4%, and there was only 2 cases with severe venous insufficiency that had no occlusion. So that's my opinion, how the future of phlebology looks like. More and more patients will be treated with endovenous procedures. The non-thermal, non-tumescent procedures will become more common. Open surgery, I'm a surgeon, will be preserved for special forms of varicoses and done by few specialists. Aesthetic claims are rising among the phlebological patients, and custom-made therapy will become the new standard. The future is now, and thank you for your attention.
Thank you so much for the very informative topic.
I think we can close the session if nobody has some very important question. Everybody can contact me today and tomorrow if you want to learn something more about phlebology. Okay, thank you.